Maria Serpa, chairperson of the committee. Before we convene, I would like to advise all individuals observing or participating in the meeting that this meeting is being conducted consistent with the provisions of Governor Gavin Newsom's Executive Order N2920. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must join the WebEx meeting. Information and instructions are posted on our website. I will announce when we are accepting public comment on the various issues, and the meeting moderator will open the lines as appropriate. I have advised the moderator to allot 2 minutes to each individual providing comments. This approach is necessary to facilitate the meeting and to ensure that the committee has opportunities to complete its necessary business. And as you can see, we have a very full agenda today. I appreciate everyone's understanding and patience as we navigate through this meeting format for our meeting today. I would ask staff moderating the meeting to provide some general instructions on how to participate at the appropriate times throughout the meeting. Can you provide that information now?
Yes, this is the moderator, and during public comment, we will be using our question and answer feature within WebEx. To access this feature, you will be looking for the Q&A icon on your screen, typically at the bottom right corner. You will then type, "I would like to make a comment," into the ask field and submit that to all panelists. We will be taking public comments in the order that they are received, and you will have a 2-minute time limit for your public comment. I will be also providing a 10-second reminder when the 2 minutes is about to expire. Once your 2 minutes has expired, I will mute your microphone and proceed to the next public commenter. During the public comment section, we will also be displaying the instructions that are currently on your screen for your use and reference. Thank you.
Thank you. I would like to now take a roll call to establish a quorum. Members, as I call your name, please remember to unmute your lines. And for the remainder of the meeting, when I do roll call, we'll do it alphabetically just so that you can be prepared. Thank you. Greg Lippy.
Here.
Jig Patel.
Here.
Ricardo Sanchez.
Here.
Debbie Veal. Debbie will be joining us in a few minutes, and she'll announce herself unless it's in the middle of the presentation. But she did sign on early and then had to be away for about 15 minutes or so. Albert Wong. Was that you, Albert?
Yeah, here. And I'd like to know who picked today's meeting.
Yeah, unfortunately, I think it's been on the calendar for a long time, but hopefully nothing exciting other than the speeches are going on today. With a quorum being established, the committee will now entertain any public comment for items not on the agenda. I can't speak, I need more coffee, I think. To facilitate this portion of the meeting, as I previously announced, the moderator will open the phone lines for individuals to provide an opportunity to provide public comment. You're not required to identify yourself, but you may do so. As we open the lines, we'd like to remind everyone that the committee cannot take action on any of these items except to decide whether to place the item on a future agenda. So we're ready for public comment for items not on the agenda.
This is the moderator. We have opened the Q&A panel for submission of requests for public comment. If you would like to make a public comment, please click on the Q&A icon on your screen, type "I would like to make a comment" into the ask field, and submit that to all panelists. We will now pause for a moment. Seeing no requests for public comment, would you like me to close the Q&A panel?
Please do so, thank you.
It is closed.
Since we had no public comment, we can go ahead and move on to our first agenda item, which is number 3. approval of October 27th, 2020 Enforcement and Compounding Committee meeting minutes. Members, this is our first order of business, and so let's please review the draft minutes for our October 2020 meeting. Are there any comments?
Motion to approve. Second that.
Again, it.
Can I suggest one change and to add to your motion?
Sure.
It's a typo on page 11, so I'm not sure if the typo needs to be added to the motion.
Well, I'm aware of it, but generally I don't do anything if they're not substantive, but it's up to you.
It's on page 11, identifying Danny Martinez of CDPH, and it's CPHA.
Yeah. Right.
So,
okay, we can change it.
thank you. And Ricardo, is that okay with your second?
Yeah,
No,
that's fine.
this is Albert. Yeah, I'm okay.
Albert, you already
Oh, I'm sorry. I'm sorry, I misheard.
Yeah, it's okay.
So let's open up for public comment.
Maria, this is Ann. To clarify, the motion was by Greg Lippy, and the second will be Albert Wong. Is that correct for the minutes?
Yes, Albert Wong, I misspoke. So we're ready for public comment, moderator.
This is a moderator. We have opened the Q&A panel for requests for public comment. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the Ask field and submit that to all panelists. We will now pause for just a moment.
I think we're not going to get any comments, so let's go ahead and close the public comment.
We actually do have
Oh.
one comment that
Oh.
just came in.
Dr. Becker.
That's actually for another item. If you would allow me just for a moment, I would like to confirm which item he's asking to comment on so that I do not miss him when the time comes. Mr. Becker, this is the moderator. I'm going to unmute your microphone for just a moment so that you can confirm which item you are wanting to make a public comment on when we get to it.
Yes, this is regarding the regulations regarding compounding of methylcobalamin, methyl B12.
Okay, thank you.
That's item number 11. Yes.
Yes. Okay, and with that, I will close the Q&A panel.
I see Virginia Osborne.
Oh, did another one pop in? Oh, she did. Okay, one moment. Virginia, I will unmute you and you will have 2 minutes. And again, this is commenting on the meeting minutes.
Hello, this is
Hello.
Osborne. I was wanting to comment on the methylcobalamin as well, so I will wait till that time.
Okay, thank you.
Thank you.
All right, I'm going to close the Q&A panel now.
With a motion and second and public comment, no public comment, we will now take a roll call. Greg Lippy,
Yes.
Jig Patel,
Yes.
Ricardo Sanchez,
Yes.
is Debbie Veal back? Okay, Albert Wong?
Yes.
Right, and the chair votes yes also. Thank you. Moving on to our next agenda item, number 4, presentation on the Pharmacist Recovery Program. Members, as a part of our ongoing education and oversight of the enforcement activities, today we will receive a presentation on the Pharmacist Recovery Program. Detailed in the chair report is information on the requirements for the board operating such a program. And as included in statute, the program is established for the to rehabilitate pharmacists and intern pharmacists whose competency may be impaired due to the abuse of alcohol, drugs, or mental illness. The statute also provides that in the intent of the program is to return pharmacists and interns to the practice of pharmacy in a manner that will not endanger the public health and safety. Consistent with those provisions of statute, the board contracts with a qualified vendor to administer the program. The current contractor is Maximus Incorporated. As an important note, the Pharmacist Recovery Program must operate consistent with uniform standards for substance abuse licensees as established in a number of years ago pursuant to Senate Bill 1441 and other statutes. You will note that all of the uniform standards, established criteria are included in the meeting materials. This includes treatment contracts and drug testing provisions. As I stated, the meeting materials have an abundance of information, but we will have a presentation. So I'd like to now introduce Virginia Matthews, who is the project manager for Maximus California Health Professionals Recovery Program. Ms. Matthews, are you there?
I'm here. Thank you.
Great, thank you. Go ahead and begin.
Okay, do we have my presentation ready to go? Thank you. Go ahead to the next slide. So I'm the program manager for Maximus. Maximus is the administrative vendor for the Health Professionals Recovery Program. Go ahead and advance. We work with 8 health professional licensing boards under contract with the Department of Consumer Affairs. So that's the overarching agency, and the contract is with the DCA. And each of the 8 licensing boards that we work with have some board-specific requirements, but the general contract requirements apply to all of the boards, and that's the bulk of what we're required to do. Just wanted you to be able to see what other boards we work with. Board of Nursing is the largest. Board of Pharmacy is the next largest of the boards that we work with. Please advance. We're going to talk today a little bit about substance use disorder, what it looks like in the workplace, and why we do what we do, what the recovery program does, and how enforcement is connected to it. Go ahead. So I want you to think about, what your perception of an addict is. We don't really use the term addict too much anymore, but it's important to recognize that it is anyone, and especially healthcare professionals, and we're going to talk in a minute, they're especially susceptible to substance use disorder, but it's anyone that you know, any professional, any healthcare professional and pharmacist. Go ahead. I'm going to talk pretty quickly because I know that you have a heavy agenda and I have a lot to cover also. So if I run through anything too quickly, let me know and I'll back up. So the brain physiology plays 2 major parts in SUD. SUD is substance use disorder. So we don't really use the term addiction very much anymore. It's recognized now as substance use disorders on a spectrum, and it's recognized as a disease process. We know that there's a hereditary component, which can make people more vulnerable to the physical dependence. And secondly, physical changes that occur in the brain caused by repeated exposure to the stimuli strengthen that dependence and deteriorate brain function. So the important components of self-regulation and motivation to remain abstinent are what's impacted by these changes in the brain. Go ahead. The ASAM is the American Society of Addiction Medicine, has a much more complex definition of addiction, but this is one piece of it. and to say that it's characterized by the inability to abstain. So that is despite the best intentions, difficulty abstaining from whatever substance or process. So we also, consider that there are other ways to have a dependence that are not specifically substances. But also then inability to, impairment in behavior control, cravings for the substance or the process, diminished recognition of significant problems in those behaviors and interpersonal relationships, and a dysfunctional emotional response. So I want you to think about individuals in your family or you've worked with or people that you know with substance use disorder, and we all have someone in our lives that's suffering with this disease process. And you'll begin to recognize that these behaviors are not just misbehavior or character flaws, but they really are related to the brain changes that occur that cause these behaviors that you see and this impact on their lives. So like other chronic diseases, substance use disorder involves cycles of relapse and remission. So we expect relapse. It's a given component of this disease. And without treatment or engagement in recovery activities, addiction is progressive and can result in disability and potentially death. And death is from the ongoing use of toxic substances that are toxic to the body. It might be related to external events such as motor vehicle accidents or fights, or it also could be related to an accidental overdose. But certainly premature death is one of the components in the progression of the disease. And I want to mention that we know now that the rate of relapse with substance use disorder and the components of the disease mimic cardiac disease and asthma and other chronic relapsing diseases, which ranges somewhere in the 65 to 70% rate of relapse. Go ahead. The spectrum of addiction. So I mentioned it's a spectrum. It's the progression of the relationship between the person and the substance. And that's really the issue. Go ahead. So when you see something pleasurable, which is a song or a touch or a food or chocolate, the brain releases a natural chemical called dopamine that trains the body and the brain to remember that I like that. That felt good. Let's do that again. Go ahead. So that's the reward system of the brain. And the opioids or the substances or the behaviors can hijack that brain's reward system by triggering a surge of dopamine. And that surge is larger than anything that nature could provide. So the repeated use of opioids overloads those circuits. And what happens is that the dopamine response begins to actually reduce. And the brain is releasing less dopamine in response to other things that were once found pleasurable. And so the person goes back to seeking more of the drug, chasing that initial high, which they never really managed to find. And they avoid that low feeling and just try to reach normal. Go ahead. So this is a graphic description of what I just talked about. And if you look at the green line as baseline or quote normal, and you have that first stage of use of a substance where an individual, and especially think about maybe college students or high school kids, and think about someone that maybe you've known with this disease and how it progressed. In the early stage one, it's experimental. They're learning how the substance works, how to control the degree of mood swing related to using the substance. Very often it's out of control in those early stages. And intoxication or freedom from stress is added to their priorities. they begin to recognize that, I like that, let's do this again. So the priorities are what you would normally expect to see in a healthy, functioning individual: family, friends, school, sports, activities, and using the substances just incorporated in there. Stage 2 begins to progress to routine use, and you'll notice that they're beginning to slip slightly below the baseline of normal in every day. And they're beginning to learn that negative consequences are accompanying their use. This might be the first time that they get a DUI. They're increasing tolerance for the substance. And they're also learning that they don't get as high or feel as good as they used to when they first used. And there's a lower crash after use, and then a return to normal. And their priorities begin to fall off. And so you'll see that their family and friends, and they begin to make new friends associated with the substance use, or they might isolate and lose and separate from their friends and their family altogether. School and job is still a priority, and they're still functioning, but getting the substance becomes more important, or pursuing that behavior. So we also talk about behavioral addictions, and we don't work with them in our program, but they follow the same process and the same reward circuits in the brain. So those behavioral addictions are things like sex addiction or gambling. Those are the kinds of things that also follow this same reward process. They get into stage 3 and they're into the abuse stage. Their baseline is far below normal. They are getting to the point where they're using to feel normal. The reward that they get from the substance use is not as rewarding as it was early on. They begin to lose those dopamine responses, and they start to see loss of control, a change in their values. Their rules for themselves are beginning to be broken. So this is where you'll hear, I can quit anytime I want. I'm not going to use for the next 30 days. We're going to do dry January. I don't know if you've heard that, but the news is talking about the last few years. January is the dry month, and individuals are challenged to get through the month of January and not use their substance or not drink alcohol. And so there's a few new alcoholic beverages out there with 0 alcohol. But they find that they can't make it through the whole month because something comes up that's they perceive would be much more fun with the use of the substance. So this is where they're wanting to use. They can't do an activity or go to any event without accompanying it with alcohol or marijuana or whatever substance it might be. And their priorities begin to change to getting the substance begins to rise to the top. And that's always kind of on their mind, and there's an awareness of wanting to have a supply on hand. The other priorities begin to fall away. And finally, in the last stage 4, the baseline is far below normal, or the normal baseline. And when they use just to hit the baseline, and then they fall down far below again when the substance wears off. They're using to survive. And I've heard participants tell me that it feels like trying to grab oxygen with a plastic bag over your head. That feeling of desperation, that feeling of needing to use their substance just in order to hit that normal. They're not getting high anymore. And important to remember that when we're talking about people that are this far into the stage of the disease. And we recognize it when we work with them in our program. They begin to lose their self-esteem, their values. They're conflicting with their own personal values. They know that there are problems with what they're doing. They recognize the relationship issues that have started to happen, and but they don't know how to resolve it. It's a high suicide risk at this point, or a high risk of accidental overdose. And they feel that when others begin to talk to them about it, that others are intruding. and they become defensive. The brain has hijacked their rational thinking, and they're really feeling that they need the substance to survive. Go ahead. So the physical component of substance use is that they may experience withdrawal symptoms when the substance is discontinued. And that usually ends within days or weeks. That initial withdrawal doesn't really last that long. There is a post-acute withdrawal syndrome that can last up to 18 months after use, with sort of intermittent appearance of some of the withdrawal symptoms and cravings and that sort of thing. But they're not, the actual physical component typically doesn't last very long. So people think, I can stop anytime I want. I don't go into withdrawal, so I must not be addicted. Well, that's not the case either. So next slide, because there's the psychological component. And they begin to find that they can't enjoy activities without using the substance. They believe they function better under the influence of the substance. I had a dentist tell me once that he was absolutely certain he functioned much better when he was using Vicodin. And he was using up to 40 a day. But he really believed that improved his functioning. And they're in a relationship with the substance. And it becomes a very personal relationship. And it's a love-hate relationship. And that psychological component, that can last a lifetime. They may not be using, but it's what we talk about, that when they're in recovery for the rest of their lives, because they never actually recover. It's never over. It's one day at a time, and it continues for the rest of their lives. Go ahead to the next slide. Health professionals are at a slightly greater risk of substance use for a number of reasons. We're going to talk about that in just a second, but the availability and the attitude and the kind of the cultural response to substances tends to be leaning toward the use of substances to cope. So they know that healthcare professionals have a slightly higher chance of, or a rate of, being diagnosed with substance use disorder. And we know that in our program, the relapse rate hovers around 13% during the first 4 years of recovery, where the general population is somewhere in the 65% range. And that's what I mentioned earlier. It's on par with other chronic relapsing diseases. So that 13% relapse rate speaks to the power of the program that we're offering, in that they get support and monitoring and learning new tools that help them to remain abstinent from substances. We learned that 75% of the relapses that we saw in our program occurred during the first year of participation. And of that 75%, 80% of those were within the first 6 months. So we know in our program that first 6 months to 1 year is when the participant is especially susceptible to relapse and especially fragile. And so we start out with a higher frequency of contact with them. We start out by helping them focus on their recovery activities rather than on working. And we keep them focused on their recovery. And in the end, the relapse rate is much lower. Okay, go ahead to the next slide. So guilt and shame are key factors that lead to the coping mechanisms that you see in substance use disorder. So guilt is that I've done something bad, and shame is I am bad. I'm a bad person. And those are things that start to occur in the thinking of an individual who's recognizing that their use of substances is out of their control, and that they're using them in an unhealthy way. And so their coping mechanisms to cope with that feeling of guilt and shame includes things like anger and hostility, control, manipulation, all those things that you see on that list. Overreaction, blaming. And so you again think back to a time when you've had interactions with an individual in your life who is suffering with a substance use disorder and how those behaviors manifest themselves in your relationship and in your lives, because the brain is working very hard to protect the use of that substance. Go ahead. So there are two key factors for healthcare professionals, especially, that make them susceptible to substance use disorder. That's attitude and accessibility. Go ahead. And the attitude, health professionals, pharmacists, nurses handle powerful substances every day. And they see the effects of these substances, the positive effects, and they become insensitive to the risks of the medications. Go ahead. Their healthcare professionals tend to be outward focused and very little self-care. Substance use or addictions are reluctantly identified because of cultural kind of attitudes that we learn early on, accompanied by shame and denial, and they have a tendency to feel immune to it. So in healthcare settings, you'll hear healthcare professionals talk about patients or talk about others as drug seeking. They tend to downplay or speak negatively about patients that are coming in with pain or requesting other medications. They may have a substance use disorder, and they're seen as weak and manipulative. And, it goes back to what we talked about earlier, that those behaviors are related to that desperation to feel normal and to replace that substance in their system. Go ahead to the next one. The substances are readily accessible. In many settings, they're poorly controlled, especially in surgical suites and in offices. Anesthesiologists are notorious for not labeling and not controlling their substances. Narcotic waste policies are not consistently followed, and we see our participants prescribing for themselves or for other family members or friends. Go ahead. And that the work is very stressful, physically and emotionally. They're on their feet for 12 hours a day in many cases. Very fast paced. They have to be on alert, aware of what they're doing. And there's that belief that the use of alcohol and drugs is okay to cope. So there's that, let's go out after the end of the shift and go have some drinks to cope with their stressful lives. Right now with the pandemic, it's that much worse. The healthcare professionals are dealing with their fears, and they're facing the stresses of being short-staffed, being exposed to the virus on a daily basis, fear that they're taking it to their family members when they go home at night. They're seeing people die without family members with them. And so the stress of the job is incredibly high right now. And there's a cultural understanding or belief that use of drugs and alcohol is okay to cope. I'm going to go have a margarita when I get off of work. Well, that very quickly escalates. Go ahead. In healthcare settings, so I'm going to move off of the disease process and talk about what we see in healthcare settings. And this is for all healthcare professionals, not just pharmacists, but it kind of overlaps between professions. So we'll see discrepancies in narcotic counts, frequent errors, discrepancies between the physician's order and the drug records. Prescriptions. Now there are new controls on prescriptions, so this is less likely to occur anymore with pages missing from pads because of the new controls in the electronic, the electronic prescribing process now. We'll see disappearing fentanyl patches. They disappear off of patients. There's approximately 30% of the substance remains in the reservoir at the end of the period of use for the patches. And so that can be removed from the patches and either boiled down and injected or chewed. But fentanyl patches are a popular form of diversion of narcotics. We should always consider that diversion might be occurring for someone else and not for the person themselves, the licensee, that they might be diverting as a codependent person and a supportive person, enabling a family member to have a substance use disorder, and so they'll divert for someone else. And they may need frequent reminders to complete their records appropriately. They're defensive when they're questioned, and it's amazingly easy to tamper with the tamper-proof vials and systems that are used in healthcare settings now, and that desperation, desperate people do desperate things. That desperation to obtain the medication, people get very, very creative in how they might tamper with the systems or the medications, the vials. Go ahead. You might see changes in the patterns of administering or ordering or processing orders. Coworkers begin to notice odd behaviors, that the individual is leaving the workplace for long breaks, going to the bathroom for a longer period of time, leaving the office to go to the car. They come in at odd hours. I had, when I was working in a hospital as a hospital administrator, had an employee who kept coming in on his days off to have lunch with his friends. We discovered later that he was using that time to have access to narcotics. The staff gossip. They're with them side by side every day. And so they see these behaviors and they see things are off. They'll see that narcotics might be missing and they'll gossip about it or come in and complain to a supervisor. And I was guilty also of, I had staff coming to me about an employee they felt was diverting drugs for himself, and I thought they were just bullying him. I thought they didn't like him and they were picking on him. Turned out it was true. He really was diverting the medications. Complaints from family members and the patients that the patient's not getting relief from the pain meds. So that means that somewhere along the line of the distribution, that there's a break in the purity of the substance. So maybe someone has withdrawn some of the medication and replaced it with normal saline, or there are other ways of tampering with the substance. And so when it gets finally downstream to the patient, what they're getting is a diluted form of the medication, or maybe no medication at all. And so they begin to complain that they're not having relief from the pain medication. And along those same lines, the nurse or the patient asks for more or higher doses, PRN doses, because the meds are not effective. And that's a red flag. So when we teach in hospitals and healthcare settings, a similar presentation to what we're doing here today, we talk about that and how they can watch for tampering or any kind of inconsistency so that they can begin to identify diversion in the hospital setting, because that's a very risky situation when the patient's not getting what they need in standard doses, and then the physician comes along and increases the dose or the frequency so that they're getting more, and then they get some of the actual medication. Now they're at risk of an overdose. Go ahead. So let's see. I think we missed one slide. Should back up one. Okay. Okay, well, I have a slide that's not there. So let me mention that the recovery program is for healthcare professionals with substance use disorder and or mental illness. Co-occurring disorders are somewhere in the 60% range. So co-occurring meaning they have a diagnosed substance use disorder and a psychiatric disorder. It's very, very common to see both. or a mental illness alone in which an individual is self-medicating to control the symptoms. And the program is voluntary and confidential. And even if an individual comes into the program as a result of their probation terms, they did agree to those terms. So they're in the program by agreement to participate in the program. And the actual fact that they're participating in the program or any of the details of their participation remains confidential. And we monitor and provide ongoing support and case management. So the goals of our program are to protect the public. That's number one. And number two, to return the healthcare professional to safe clinical practice. And we do that through intervention and rehabilitation. Go ahead. So who is the program? Well, the program revolves around the participant, and the components are the board, Maximus as the vendor, the support group facilitators, the evaluation committee, also includes the community meetings that they attend, and when they work, it includes their worksite monitor. Go ahead. Next, yeah. And it's important to recognize that most healthcare professionals do not self-refer. Very close to 90% or higher of our participants are referred into the program by the board through probation. They really don't refer themselves unless they see trouble coming, unless they see that they are going to be having some action against their license down the road and they want to get a jump on it. We occasionally see people self-refer, but for the most part, they're not self-referred. And they rationalize the consequences of the drug use. You know, that goes back to that cultural belief and the way that substances are used in our society. So the role of a caregiver is enmeshed with the professional's ego and their drug use, and the effects of the drug use are minimized. So we have an awareness of all of those components as we work with our participants. So next, the licensee meets admission criteria if they're licensed and reside in California. They have a diagnosed substance use disorder and or mental illness. They voluntarily request or agree to admission in the program, and they're referred to the program as a term of their probation. Go ahead. They do not meet the admission criteria if they've been disciplined by the board for substance use or mental illness in the past, or previously terminated by the program or a similar program for noncompliance. We do occasionally make exceptions in those cases. We look at the individual case and what the background is and what their current situation is. And at the after a discussion with board staff, that we may consider admitting somebody who does have some of those criteria in their history, but we'll bring them back into the program. Go ahead. They might be denied admission if they've diverted drugs for sale, or they present too great of a risk to the public. There's been very clear and measured patient harm. In those cases, they are not able to join the program. Go ahead. So self-referral, they can contact Maximus to request admission at our 800 number. We have somebody on call 24/7. So if they're not able to reach us during business hours, we do, we do take the information from them and get back to them on bringing them into the program if they need to, or it may be included in terms of their probation stipulated agreement. Go ahead. Our responsibility is to maintain this toll-free number 24 hours a day, 7 days a week, and we conduct a comprehensive assessment of applicants. Go ahead. I apologize if you can hear my dog barking in the background. Our responsibilities are to monitor and support applicants and participants. That's our case managers. They're all registered nurses. They're all with experience in substance use disorder and psychiatric nursing. Ann Morales is the case manager that works specifically with the Board of Pharmacy participants. She has a very close relationship with them and speaks with them on a regular basis and knows the cases very well. So she's providing support and holding them accountable for meeting the requirements of the program. Go ahead. So we verify eligibility. We do that through discussion with the board. We conduct an initial intake. That's the case manager that does that. It takes about an hour and a half of telephone interview based on the addiction severity index and information from the American Society of Addiction Medicine. And then we send the individual for a clinical assessment, currently on Zoom, but in normal times in person, with a licensed clinician who's might be a marriage and family therapist or a psychologist, other healthcare professional. Most of our participants enter into treatment when they come into the program initially. It's a decision made in concert with the case manager, the clinical assessor, and the board staff, but it depends on every individual case. Now, if somebody just came out of treatment and they come into our program, they don't need to be re-entering into treatment. But if they come into the program and they're still actively using, then they get a very high level of treatment, such as detox or inpatient residential treatment. We also utilize, in addition to that in-person clinical assessment, a 3-day assessment for healthcare professionals. It's used pretty extensively by the Board of Pharmacy, and where there are a few facilities that are recognized for providing treatment that specializes in healthcare professionals, their unique needs. And the 3-day assessment is a multi-system, multidisciplinary assessment that looks at their level of functioning, their families, their personality inventory, medical issues. It's a very thorough assessment that they do over a 3-day period. They talk to family members, they do collateral interviews, and come back to us with a recommendation for whether the individual is appropriate for further treatment or safe to return to work. Those are all components that are required of us by those uniform standards that were mentioned in the introduction. When an individual comes out of treatment or when they become available, they're required to have weekly communication with the Maximus team until they're reviewed by the committee. Go ahead. And they have to start attending community-based support group meetings. Typically, they're 12-step meetings, not 100% of the time. Sometimes they're other types of community support group meetings, or there are a number of groups that are available by for mental illness or psychiatric disorders. And we have them start with daily meetings and ask them to attend a minimum of 90 meetings in 90 days. So daily for the first 3 months, and usually extends beyond that. They also attend a peer support group. They usually start out twice a week and then reduce to once a week much later in their program. And the peer support group is run by licensed clinicians. We use a specific group of clinicians and refer the participants into those groups. Random drug testing is tightly managed by the uniform standards, and so we subcontract with a third-party administrative vendor that organizes the drug testing for us, and then they have analytical labs that they utilize to actually conduct the testing. So participants have to check in daily with the lab, and then we utilize primarily urine testing, but we also use hair tests. If hair is not available, and we've had people show up that have shaved their whole body, we can use nails. We can use any body hair. And so we do an initial hair test and a blood test for alcohol. It's called a PETH, P-E-T-H. And that test looks at the last roughly 3 weeks of for use of alcohol. There's a roughly 3-week window. The hair test has a roughly 3-month window of utilization to look for utilization of substances, but does not include alcohol. So we use both. And then during the course of the participation in the program, they'll have random hair and peth tests at least once a year or as needed after that. So drug testing is pretty extensive, and our drug test panel is more extensive than most programs use. They actually call it the California panel. And so we have very low cutoff levels and a more extensive panel of substances than most programs use. We've recently started including additional substances on a random basis, and we have begun to identify some substances that we had not identified in the past. So by expanding our test panel, it's allowed us to identify other substances of abuse in the community. And then the individual is reviewed by the committee, typically within 30 to 90 days. It's usually within 30 to 60 days for the Board of Pharmacy. The next time the board meets, they typically review the case. They look at everything associated with the case, including the all of the assessment information, the drug testing, the recommendations from the support group facilitators, recommendations from the case manager, and all of that is taken into consideration to continue to work on planning. Go ahead and change the slide. Planning for the individual's progress in the program. So this committee meets monthly, reviews each of the participants at least once every 3 months, more frequently if they need to be reviewed. This is where the participants are formally accepted into the program, and this is where their ongoing recovery plan is evaluated and established, and any changes that are requested by the participants are reviewed in this committee. And it's attended by Board of Pharmacy staff and Maximus case manager, in some cases other Maximus representatives. Go ahead. Participant has to apply to return to work. So they have to complete an essay for us telling us why they believe they're ready to return to work. We have them do a relapse prevention plan because in many, many cases, they're returning to work where their substances are available to them. And much of what was going on in the workplace is a trigger. So we have them contemplate all of that and look at the risks and what they will gain by being able to return to work, and what what they need to be, how they'll manage those risks. To have them prepared to return to work, we also look at their compliance overall with the program requirements, their drug test results, their recommendation by their support group facilitator, and the evaluation committee, the PRC, reviews all of those things and makes the determination. The other thing that happens is that the PRC, once they've identified a workplace, go to the next slide, will look at the workplace and make sure that it's has a clean record and it's appropriate for where the participant is requesting to work. They must identify a worksite monitor in the workplace that is an individual that sees them, and that level of supervision depends on really every case individually, and that's determined by the PRC. So they may have 100% supervision by the worksite monitor. It may be 25%, or toward the end of their program, it's very low. So it really is kind of on a sliding scale and depends on the individual's case and what they need, what their history has been, whether they've diverted from the workplace, whether they're being faced with those triggers again in the workplace. And they may not serve as the pharmacist in charge. Go ahead. The participant has to give us a release of information to speak to the worksite monitor and the employer. That's required by those uniform standards. We have an agreement that the worksite monitor signs, and we provide training to the worksite monitor, and that includes, we have a video now that's available for them to watch, and it reinforces all of the things that we're providing them verbally. about how to monitor, how to identify a relapse, what it is we're looking at with this individual participant. Go ahead. So they have to, again, we provide training to the worksite monitor. They must submit an organizational chart showing us that their worksite monitor is at least one step higher on the org chart. We look at the job description and make sure it's in compliance with their restrictions, and that they have to have a affidavit by the worksite monitor that they meet all of the requirements, that they've been trained, and they agree. And one of the things they agree to is to contact us within 1 hour if they identify any signs of a risk of relapse, any changes in behaviors, any errors that are of concern, that they're expected to notify us within an hour. Go ahead. We have a final year before completion of the program is transition, where the participant has a slightly reduced level of monitoring. And it's kind of how we get them to begin to monitor themselves and use the tools that they've learned while they were in the program, and maintain their sobriety with their own level of monitoring. So they're still required to have a worksite monitor. They're still required to drug test. They're still required to check in with us and do a monthly self-report. But we don't require them to continue going to 12-step meetings. We strongly encourage them to continue, and they're not required to attend support group meetings. And again, that's something that we encourage them to continue doing for that level of peer support. The participant must write an essay requesting transition, and really autobiography of how they got here, what their life was like as a child when they began using the substance, all of what contributed to bringing them where they are today, and then how their journey has been in recovery. They have to develop a thorough relapse prevention plan and get letters of reference from key individuals in their lives, family members, their sponsor, support group facilitator, to talk about what progress they've made and are they in fact ready to move on. Go ahead. They have to demonstrate, in order to demonstrate a manner of living that supports ongoing recovery, and have proof of negative drug tests, negative hair and alcohol tests, and all good history of good compliance. Go ahead. Program costs are always a concern. So initially, the intake assessment is free. The clinical assessment is free. If we have them attend a more intensive 3-day assessment, they do have to pay for that. It may or may not be covered by insurance. Treatment program costs also vary, may be covered by insurance, and that widely varies depending on where they're going for treatment and what level of treatment is required. Board of Pharmacy participants pay a monthly $100 of copay for the administrative fee. Go ahead. Support group cost varies anywhere from $200 to $400 per month, depends on who the facilitator is and how often the participant is attending. Any healthcare costs are the responsibility of the participant. And the cost of drug testing is $57.50 per test for any of the random drug tests that are scheduled, including hair and blood tests. If there are additional tests scheduled for cause, those may have a higher fee. And that rate is varied depending on what type of test they're having and what's on the panel that's being tested. And then if they're testing at an in-network collection site, it's $30. And if they're out of network, it's $50 for the collection fee. Go ahead. In order to complete, no other evidence of relapse within 24 months and at least 24 months of satisfactory participation. Go ahead. And recovery works. And so to close, I would like to read a couple of quotes that come from our participants. And so, as I mentioned, they are required to do an essay for us at the end of before they enter that last transition phase, that last year of participation in the program. And in that, we've pulled some quotes, and I'm only going to read a couple because I know we're tight on time. But I would say, this is anecdotal and I'm estimating, but I would say at least 80%, if not more, of participants that complete our program say that we not only saved their license, but we saved their lives or saved their marriage. But and we have about a 68% successful completion rate in the program. So that's pretty good, and compared to other programs across the country, we have a pretty good completion rate. So I'm going to read a couple of quotes for you. My life goals and objectives have evolved greatly since I've been in recovery and in the Maximus program. It's safe to say that before recovery, I was living by the seat of my pants, always chasing the next fun outing or excuse to drink with friends and barely getting enough sleep to function efficiently at work or to have enough energy to spend quality time with my loved ones. Now I feel that my focus in life is not so much about what I get out of life, but more about what I can offer in life. It's been fulfilling to get out of my own head and to realize there's a lot more to life than just drinking and not really remembering everything I said or did. Another quote is, I want to personally thank my case manager and compliance monitor, as well as the Maximus program, for helping me restore my family and my life. A few years ago, I lost everything. This program and what it has taught me is that I am nothing without my recovery. My dad and I have a relationship and he trusts me. We can be better than that. And sobriety has offered me the opportunity to make the most of my life and present a strong and healthy example to my children. Despite my initial hesitancy and resentments toward the Maximus program, I can now recognize that they saved me, and I would not be in the wonderful place I am now without it. So I'm going to open up if you have any questions. I'm open for any questions or concerns.
Thank you, Ms. Matthews, for this excellent presentation. I am sure we do have a few questions, so I'd ask members if you have any questions or comments.
Maria, I have a question.
Go ahead.
Thank you. We frequently require the program when we have disciplinary cases where we have probation. And we frequently hear that the costs are astronomical. Now, your presentation on the costs gave part of them, but certainly not all of them. And I don't expect that you can give them all. But what I'm wondering is there some kind of an average or a maximum or minimum that somebody can expect to pay when they go through the entire process?
So it's $100 a month as the administrative copay. The uniform standards require a frequency of testing that we have to follow. And so initially, and I don't know if we want to discuss that, it is a public document, but we try not to discuss the testing frequency with the participants because the value in it is the randomness of it.
Understood. But what I'm looking for is really, is it something that's going to cost $5,000, $30,000, $50,000? What can somebody, I mean, so that we know when we delve out these requirements, what we are putting somebody, in the process to be, that it's going to cost them.
The first year of testing is probably close to $5,000 plus the $1,200 administrative fee. Those are the set fees. Mm-hmm. Anything additional is a variable. So where they go for treatment, whether or not their insurance covers it, if they even have insurance, what their support group facilitator charges, those are all variables. So it's hard to put your finger on those. The first year is clearly the most expensive, and then the frequency of things reduce after that, so the costs will go down.
Okay.
Greg, this is
yes.
Yeah, Greg, this is Ann. I just wanted to highlight that under the provisions of the contract, we also have provisions for participants to for the board to waive their administrative fees, for a period of time. So it's pretty routine that we do that. The other thing is that where insurance doesn't cover, it's pretty common for us to try to help the individual find maybe a county bed or something else that is not as expensive. So we try very hard to be, cognizant of the cost to make sure that that's not the barrier to them participating to the extent possible. Thank you.
Okay.
Thanks,
Thank you
Ann.
both.
That's a great point. Thanks, Ann.
Thank you.
Hi, Maria, this is Debbie. I'd like to ask a question.
Go ahead, Debbie.
Wonderful presentation.
Thank you.
Kind of going along with what Mr. Lippy was just asking. So that first year, it seemed like from the presentation, probably they aren't working. Would that be a correct statement? Because it seems like there's a time period where they aren't working, and then they, apply to the committee to, be able to go back to the work site.
It's true that they are removed from work initially, and again, each case is individually evaluated to determine when they're safe to return to work. Public protection's the primary focus. So it depends on when they complete treatment, what their history has been. There are many, many variables, but it's typically not as long as a year.
Okay.
And I don't, maybe Ann or Debbie can give you an average, but I don't know the average time that they're kept out.
Yeah, this is Ann. I would say that it really depends on where they are in their scope and pattern of use. The uniform standards establish some criteria for it. So of course we have to absolutely follow the uniform standards, but typically, someone referred for maybe a single high-level DUI that presents and doesn't demonstrate, significant patterns or whatever might be at a lower end of, as cease practice, whereas someone that has a significant history of use that's maybe doing 90 days of residential treatment and those kinds of things, the clinical picture is just very different. I would say that a year out would be a very rare exception. I don't think that is where the majority of our participants fall. And the other thing to note is that there are times when, although the program is allowing them to return to work, the individual does not return to work for, a variety of reasons. So sometimes it is a restriction within the program itself, but sometimes it is either a personal choice or difficulty finding a job, those kinds of things.
So, Ann, when you say a year out is kind of the exception, you're saying that most people return to work before that.
Yes. And
okay.
Like I said, I would say that it really does depend on their presentation
I
at the time. Yep.
Yeah. I just wanted to clarify that. And then it seems like, the testing is, I know it's required, but it also seems like it's very necessary. And there's like a really fine line between less testing, because then you might not, the behavior could return. I mean, do you agree with that?
The value of the testing is in the randomness of it and the frequency, but the participants really don't know when they're going to be selected to test or what's being tested. So there's some value in that, just helping, and it's not in a tricky way, but in a way that helps them to manage the cravings and their triggers for use. It's a deterrent.
Okay.
I'm not sure if that answered your question.
It seems like a valuable deterrent, but yeah. Okay.
Yeah, and it's really the only true measure we have of determining that they're maintaining their sobriety.
Yeah.
Maria, I have a question. This is Albert.
Sure, Albert, just 1 second. I'd like to make one announcement. So many minutes can reflect that Debbie Veal did join us during the presentation. As stated, she was present and able to ask questions. Thank you. Go ahead, Albert.
Yes, I most those people when they abuse drug, they will be fired. They usually get fired from the job, and they probably most of them probably don't have health insurance after that. So it will be cost them a lot more than I think the what the copay is. So how we take care of those patients who cannot afford when they our job and they our insurance.
So many of them do have the ability to either continue their insurance with COBRA or to utilize the public insurance that's available, either Medi-Cal or the Obamacare options. And so there are more options now for insurance than there used to be in the past. And we work with looking at other providers that are less expensive when they really don't have any option to pay.
Okay, I got one last question.
Mhm.
And how you guys do those? What happened to those that require the detox? This is not in on-site treatment. This is so how you guys do the detox?
So we're not a treatment provider. So we make referrals into treatment and we monitor participants' progression in treatment, but we don't actually provide the treatment. So we know what facilities in the state and even a few of them out of state provide detox services. We encourage, and when an individual finds a place that they want to go for treatment, or if their insurance covers it, we still have to approve it. So we know the facilities that we've had issues with or the facilities that have been that have done a good job with our participants, and we try to work within that. We make sure we work with them, we're supporting them. So we'll say, for example, we don't want them to stop using a substance abruptly, that it needs to be medically supervised detox, and help them to identify where to go.
So you guys take over after the detox finish, right?
Yes, I mean we're still involved in the case even before then, and we'll get treatment provider reports, and so we'll hear from where they went for detox or for inpatient. Sometimes they'll go, continue on inpatient treatment or residential treatment after the detox, and so we work with the treatment providers.
Okay, thank you.
Okay.
Maria, I have one more question, just because we do hear so much about, the cost of the program. Do you very often have people who drop out of the program solely because of the cost?
In the last year in the program overall, so this is not just a pharmacist, but overall in the program, we recorded 3 people that dropped out due to program costs.
So to paraphrase that, maybe it sounds it's pretty rare that it happens. Right.
We started tracking it a few years ago because we were concerned that we were losing people related specifically to the costs. So yes, I think it'd be a fair assessment. I mean, we do have people that withdraw and costs maybe a piece of it, but people that are truly just dropping out due to costs, there were a total of 3. And I'm sorry, I don't remember exactly how many closures we had during the last year, but it was probably 130 closures. So.
Okay.
Jenny, would you mind, Jenny, this is Anne. How many total participants are in the program across the 7 or the 8 boards?
There are about 430 total participants in the program.
And I think I read from the minutes or from the report, chair report, that like about 65 of them are us.
That sounds about right. That's very close. If it's not Exactly right. It's very close.
Any other member questions or comments? Okay, let's move on to public comment. Moderator, please open the lines.
This is the moderator. I'm opening the Q&A panel for requests for public comment. If you'd like to make a public comment, please click on the Q&A icon on your screen. Enter "I would like to make a comment" into the Ask field, and then submit to all participants. This is the moderator. We do have a request for comment from Stephen Gray.
Great. Go ahead, Dr. Gray.
Long list of participants. Mr. Gray, I have unmuted your microphone. You will have 2 minutes.
Thank you very much. This is Steve Gray. I'm commenting on behalf of the California Society of Health System Pharmacists, CSHP. First of all, it was an excellent presentation, the best I've ever heard on this subject. Thank you very much.
No, thank you.
Also like the congratulate the board on this program. It has been very helpful and important to the safety of the public and to the respect of the profession overall. CSHP, however, continues to suggest that this program should be open to pharmacy technicians, licensed pharmacy technicians in California. They are taking a greater role, a more important role, and we all know from experience that this is a category of people that also have their problems along these lines. Many of them do have insurance coverage. They work for organizations that provide them health insurance that can help with the cost. More and more of these people have invested more in their profession, and their employers have invested in their profession, and the public is becoming more and more dependent upon the quality of and the availability of our pharmacy technicians, both in the hospital and outside the hospital. And a good example is during this pandemic. So we would encourage the board to put on its future agenda a discussion about opening the program and supporting opening the program through legislation or whatever to also pharmacy technicians. Thank you for the opportunity to comment.
Thank you.
And at this time, that was our only request for public comment. Would you like me to close the Q&A panel?
Please do.
It is closed.
Okay. Members, any other questions or comments? Otherwise, we're going to take a short break. I'm just going to pause here for a second.
I just want to thank you for the opportunity to having me this morning. I very much appreciate the opportunity to speak with you.
Thank you, Ms. Matthews, for your time and expertise. You really have brought a lot of information to the board and to members of the public. I appreciate that.
Thank you. I know it was quick. I know I apologize for that.
No, it's great. So this presentation will be a part of our minutes. Is this something that will be placed on the website also? Anne, is that possible?
Yeah, so the meeting is being webcast, and so we will be posting the webcast as well.
Right. Perfect. Okay. Thank you. So since this is a good opportunity to take a short break, it's a little bit early, but because we have some meaty subjects coming up, let's take a 10-minute break and reconvene at 10:30. Hello all, welcome back. We'll do a quick roll call to assure that we still maintain a quorum. Moderator, are you there?
This is the moderator. I'm here.
Great. Okay, so we can go ahead and start recording, and I'll do a quick roll call.
Sounds good. You may proceed.
Thank you. Welcome back, everyone. We will do a quick roll call to assure that we still have a quorum. Greg Lippy.
Here.
Jig Patel.
Here.
Ricardo Sanchez,
Here.
Debbie Veal,
Here.
Albert Wong, Albert Wong. I'm sure he'll join us in just a minute. Let's move on. Our next item on the agenda is item number 5, discussion and consideration of board policy relating to transparency involving the issuance of citations and fines. Members, this next agenda item is a continuation of an issue originally discussed in 2018. This was related to the board's disclosure policy on citations and fines. The history of the prior discussion is detailed in the chair's report, and I trust you've had an opportunity to review it. As noted in the materials, in July 2018, the board referred this matter back to the committee for further consideration, expressing concern with potential negative impacts to consumers while balancing transparency. To help guide our discussion today, there are several policy questions included in the meeting materials. I would suggest that we consider these questions as a part of our process and discussion today. Because of the WebEx meeting format, I recommend that we review each question individually. I will share my opinion and then ask members for their thoughts. After we completed all the questions, I will open up the discussion for public comments on the entire issue. Members, do you have any questions on this process? Okay, let's go ahead to go to the next slide, and then let me just check and see, is Albert Wong joined us?
Yeah.
Is that you, Albert?
Yes.
Okay, great, thanks. So these are the questions that were in the chair report. We found it easier to have a slide so we can all look at it together. So let's start with the big picture. I think having a clear understanding of the policy goal is important. So number 1 says, what is the larger policy goal of the board? As I understand it, our current policy goal is to provide transparency on disciplinary actions. This does not include the routine citation or fines that may come up during regular inspections or investigations of complaints that do not merit discipline. Often these items are corrected quickly or abatement is offered. As we discussed in 2018, there were concerns not only about the volume of information, but that serious issues could potentially be buried in the longer list of minor infractions. Members, I'd like to hear your thoughts on question number 1.
Maria, this is Debbie, and I think the question is the larger policy goals of the board. Do we need to include these citations in public notice? Is that what the question is? Do we need to change our current policy?
There's a potential in the other questions to discuss changing the current policy and how to change it. But the first question is just understanding what the current policy goal is.
Okay.
And the reason why it's there.
So from my viewpoint, the current policy goal is to, our number 1 objective is to protect the public. And so to make sure that the public is aware of any kind of discipline that may be happening and really to kind of make, let me just stop there, period. I think that's our current policy. I think that's where our policy goal should be.
Right. So that is the appropriate goal. It's how we accomplish that. Thank you, Debbie, for clarifying that. Any other comments on number 1?
Just that transparency, and being very informative. Definitely should be a policy goal.
Thank you, Ricardo.
Maria, this is Jig. I feel that the volume of citations and to separate which ones needs to be posted and which ones don't need to be posted would be important, because if we post every single citation that's given and collected by board, that would be a lot of data.
Thank you. That's kind of going into number 2. So maybe you can continue on, Jig. Are there any unintended consequences if the board changes its current policy? And so that would mean changing our current policy to post citations and fines.
Maria,
I think go ahead.
go ahead.
I was going to say, I think Jig has a good point there. As it is, a lot of our licensees don't really come forward because they think that we're really harsh, or we're going to rule against them and so forth. And I think we've been building up a pretty good rapport with some of our actions that we take when we deal with some of the disciplinary stuff. And if you put everything out there, every single citation, it may scare folks off to, willingly come and talk to us or try to fix a situation.
Yeah, Maria, I have a comment.
Go ahead, Albert.
Yeah, our goal and objective is, consumer safety and protection. But if there's other method of accomplish that, or lesser, harsher way of, accomplish that, then we should try to use that instead just punish them every time. But if simple violation, if something we could educate them and correct the problem, and and accomplish the protection of the consumer and the safety, then we should approach that way.
So the issue at hand is not whether they get a citation or discipline or a fine, but how and when and what is posted on the website. So the what I'm hearing about some of the unintended consequences are that it could be a long list. And one of the things I had previously mentioned too is that it could be things that have already been corrected just from a routine discussion during an inspection.
Also,
so
Maria,
not something that merits discipline. Go ahead, Greg.
We look at a citation as, or it is defined as something that is not a disciplinary action. And if we start, this could affect people's jobs or ability to get a job by, potential employer or a current employer looking at it and saying, well, I don't know if I want this person. They've gotten citations. And the whole idea behind a citation is that it's given for something that doesn't reach the level of a disciplinary action. And I think the unintended consequence would be that it would be looked at as a discipline as opposed to what it's intended to be.
Mm-hmm. That's a good point. And, actually, as we continue our discussion, I feel comfortable if you wanted to address any of the policy questions, because it seems like they kind of cross over. So Greg has mentioned issues for number 3 and number 4. Especially number 4 is by posting it on the website, that could be inferred to be additional form of discipline. The other part is how to, if we were to do this, how would we educate consumers and the public as to the varying degrees or the differences, so that it's not lost as to what is truly a disciplinary action versus a citation or comment.
Maria, this is Debbie. I'd like to make a couple comments. I think first off, I would like to say that I don't think we need to change our policy. I think, Greg and the others have indicated, that there absolutely would be unintended consequences. And I don't think that there's anything really to gain by putting up the citations and a lot to lose. I think, sometimes we hear about individuals come before us, and whether they can't get a job, or it's a pharmacy and it can't get, contracts, or they can't send, contracts with payers because there's discipline, or what's perceived to be discipline, or less than perfect operations. because of these things appearing on the website, I think it would cause almost discrimination against these folks. And I think Greg said it. I don't think it really comes into protecting the public. I think we're doing a good job of protecting the public, and the citations, if they warranted more and if they were going to impact the public, they would have evolved into discipline. And so that's what the public needs to be able to see and know is the discipline, not the citation, not the fine tuning.
Thank you, Debbie. I agree with your comments. Other additional comments?
Yeah, Maria, this is Jig. I agree with that, but not changing the policy. I did have a question for your staff. What kind of information do we share with a consumer who lodges a complaint with the board? And is there a closure after whatever steps board takes? Do we send a written letter or anything to the consumer who complains to make sure they know what was done?
Yeah, so board staff, I would suggest answering two questions there. The first one is about accessibility of citation and fines. Is there a way to find that information if someone would want to search that? And the second is about investigation resolution.
This is Anne. Good morning. With respect to the first question, we will provide the information if requested. So if someone requests a license verification on an individual, we will provide the license history of which the citation and fine would be considered part of the license history depending on the time period. With respect to the question about the consumer, yes, the consumer is advised of the outcome of the investigation and the resulting action.
Thank you, Anne. Jig, does that answer your questions?
Absolutely. So, as a consumer, I would want to know what happened, and we have a process in place. And so, yes, I agree. I think we have great policies in place, and no changes are recommended, in my opinion.
Thank you. Any other board comment? I thought I heard.
Yeah, I agree with Jake said that no change need to be made.
Maria, do we need to make a motion?
No, we don't need to make a motion if we're not changing anything. So is there any other board comment or suggestion? Otherwise, we're going to move on to public comment. Great. Moderator, we're ready for public comment.
This is the moderator. We're opening the Q&A panel for requests for public comment. If you'd like to make a comment, please click on the Q&A icon on your screen. Type, "I would like to make a comment" into the Ask field and submit that to all panelists. We will now pause for just a moment. Our first request for comment comes from Stephen Gray. And Mr. Gray, your microphone is unmuted and you will have 2 minutes.
Thank you very much, and thank you for allowing me to comment on behalf of the California Society of Health System Pharmacists, CSHP. CSHP also agrees that the policy should not change, that citations and other types of non-discipline action by the board should not be posted. As indicated by staff, that information is available upon request, and especially to the complaining consumer, etc. There are unintended consequences that have been discussed before. I want to make sure all board members know about it. Things that are posted on the board are often picked up by other boards of pharmacy across the country about California entities that are also licensed in those states. And they often don't understand the difference between citations as not discipline and discipline. And in such cases, they have policies that sometimes automatically lead to discipline of a license in that state, and it can then proliferate from one state to another, and where the first state issued discipline didn't designate anything about citations, and then the next state looks at that state and also. So it has really wide-ranging unintended consequences. I also, just a little bit of history, before we had citations and fines, it was difficult to get the attention of licensees. Citations and fine, as a matter of policy, were a good tool to get their attention. It started out with very low rated fines, maybe $100, $250, and then gradually it learned that for certain types of entities, the fines had to be in the above 1,000 or maybe multiple thousands. And it was a good way to generate action without having to go to an accusation, which was maybe not as effective in a way, and also caused a lot of cost, but the problems were corrected by. So it's really a tool for getting people's attention. So we do not believe it should be posted. Thank you very much.
Thank you, Dr. Gray.
Our next request for comment comes from Paige Talley. Paige, your line is unmuted. You will have 2 minutes.
Oh, great. Thank you. Paige Talley with the California Council for the Advancement of Pharmacy. First, I want to say thank you for the conversation and the opportunity to comment. Obviously, I agree with the board members that nothing should change. I did want to say, though, that Anne mentioned if somebody asks for a licensee's history, she will give it. And, I understand that. But is there some way that you can tell that whoever asks that a cite and fine is not a disciplinary action? So that, that concerns me too, because there are PBMs that will call and ask. I think. That's all. Thank you.
Thank you, Paige. Anne, did you want to respond?
So we have in the past provided a letter that clarifies it, and then as included in the board sunset report, we do have a statutory proposal where we intend to explicitly include in the statute that it does not constitute discipline, so that there be greater transparency and understanding. So hopeful that that will be included in the board sunset bill.
Thank you.
Our next request for comment comes from Nancy Fingerhead. Nancy, your line is unmuted. You will have 2 minutes.
Thank you. My name is Nancy Fingerhead. I'm calling from Lee Silsby Compounding Pharmacy. So we also agree with the consensus from the board that citations should not be made public. Often citations involve continued discussions with the board to resolve questions of legal interpretation and application of the pharmacy practice observed. So we think that this would add further confusion to the public if it's a continued discussion with the board for resolution.
Great, thank you.
And that was the last request for public comment. Would you like me to close the Q&A panel?
Please do.
It is closed.
So we'll document in the minutes that there is no action to be taken on this item. Thank you, everyone. Moving on to the next agenda item, number 6, discussion and consideration of proposed revisions to self-assessment forms. As indicated in the meeting materials, the committee will have the opportunity to review several proposed edits to self-assessment forms required under pharmacy law. As we start a discussion, I would like to emphasize the importance of self-assessment process, which is intended to be an educational and self-monitoring tool for licensees to evaluate their compliance. As members may recall from presentation that we received in July 2020, failure to complete self-assessment forms is among the top 10 violations identified during routine pharmacy inspections. Detailed in the meeting materials are some of the challenges the board has experienced in updating some of the self-assessment forms. A couple of them are still in, or several of them are still in the regulatory process from past years. To avoid confusion, this is something that I wanted to bring your attention to. To avoid confusion, we will not be discussing the wholesaler or the ADDS self-assessment forms at this meeting. We will wait for the completion of the current regulatory review before adding additional changes. We just think that it's going to be too confusing to keep to make additional changes on top of changes when we're still in the regulatory process. And there's an opportunity to make additional changes after that is finalized for those two. Before we get started, I'd like to note that suggested changes to the self-assessment forms in large part reflect changes to pharmacy law. From a process standpoint, I recommend that we review each self-assessment form separately and accept public comment on each one.
Oops. Can I ask a favor?
Who's this? I'm sorry. Okay. Someone doesn't need a favor then. Okay, please put your phone on mute. Thank you. So we're going to review each self-assessment form individually and then take public comment on each one. I would note that staff has offered recommendations on how to facilitate some of the changes through the rulemaking process. As we discuss each form, we will look to council and staff to confirm the appropriate action to avoid any additional delays. So we're going to go through them one at a time. So the first one is community pharmacy hospital outpatient self-assessment. Rather than go through each change individually, the changes are detailed in the meeting materials and summarized in our next slide. Can you post the next slide? So there are quite a few adjustments and changes to meet current pharmacy law. Does any members have any comments or questions?
Maria, this is Debbie. I'm wondering, when I look specifically at the community outpatient attachment 3, discussion item 4A. Anyway, when I look at that, it looks like that self-assessment is 50 pages long. And I'm wondering if that's part of the problem. I don't know if the staff can, tell us, do people not get all the way through the 50 pages? Because that is quite long. I think it's a very valuable tool, but I'm wondering if we have too much, detail in here. I don't know. But anyway, my main comment is this is quite a large document. Mm-hmm. And do we think that that's part of the problem?
Staff have any comments to that? I can't speak to the community one because I've only I haven't done that one specifically. I've done acute care and hospital and compounding. So any comments from staff?
This is Anne. I think a couple of comments. I think, Debbie, that question might be good to hear from stakeholders, their perception. I think that a lot of times we will find that either the self-assessment is not done or someone's just gone through and checked yes. I think the intent of the self-assessment form is to provide a meaningful tool by which people can evaluate their practice. And if the committee and board believe that we have gone into too much detail and we should, maybe streamline some of this, I think, that's a discussion for you all to have. But I think in general, at the staff level, we really use this as a tool, and we really encourage licensees to use this as a tool and a resource. So it shouldn't necessarily be a one-time, a one and done. If you've ever heard our presentation on how to prepare for an inspection, the inspectors will really talk about, this is a really good resource, not only to confirm compliance with the law, but also if you have questions about the law, because we include the legal references as well. Mm-hmm. So those are staff comments.
I know that go ahead.
I was just going to say, I don't know which committee, I don't know if it's licensing or this one, but I know I've been part of putting together some of these self-assessments, and I agree with you. Our intent was purely to be educational and to make sure that the licensees are, understand all the intricacies in pharmacy. But as I look at these, they're just, long, and I'm wondering if maybe it's too much. But I agree with you. We should perhaps hear what the stakeholders have to say, and that would be, Maria, if you've completed, it sounds like a couple of these, and Albert, I don't know if you've completed one for your pharmacy, if you found it helpful or if you found it, tedious and maybe not so helpful, because I think the intent was it was kind of a multi-purpose tool.
Yeah, in my experience, I find it helpful when used as not only as an educational tool, but as a checklist to go through and check off the ones that are easy, and then go back and look at the ones that you're not quite sure of to educate yourself more, or to talk more. I also use a couple of the self-assessment tools to assist new and training supervisors and residents, especially handing the the self-assessment tool to a resident is very informative because they may have not heard of some of these things.
It seems like this is a great tool to avoid any potential disciplinary action, because if you fill this out properly and you follow everything that's in there, I doubt that you'd wind up with any kind of a ding as a result of an inspection. But one thing, maybe if this is too long, or if it's considered to be too long, maybe one thing would be to require it every 3 years instead of every 2 years. Just a thought.
Maria, I think one of the main problem we have so many people get cited for not doing it is they're not aware of it. I think the old timer probably not aware that they have to do the self-assessment assessment every year or whatever. But I think if we have some kind of mechanism to inform them that they are required, I think that will probably better to have less people not doing the assessment.
I know that reminders do go out to the email that all licensees are supposed to be part of that group email, and it's also published in the script. Because one of the things that I think that we do well is that we have a routine, and it's all at the same time. So it's not like calendar. So some people are in January, and some people are in July, and some people are here. And everyone is required on the, I think it's in July of every other year. Also, to go to Greg's point, one of the things about keeping it often is it's on the forefront of your thoughts, so you're aware of new and changes. And then especially in some of them, I'm not sure if it's in this one, but in some of them there's annual requirements. And if you do the self-assessment and it says annually you shall blah blah blah, you have an opportunity to remediate that before an inspector comes and it's been 3 or 4 years.
We do send out a notice for licensee renewal every year, right? Can we put a little reminder that they require to do so every year?
Well,
it's every other year.
This is Anne.
Yeah.
This is Anne. So
yeah.
we do try to do the communication in a couple of different ways. We typically include around the July timeframe information in the script article, but we also include it in our monthly roundup. If you notice the monthly roundup that we send out to all of our licensees, we include not only the activities of the board, but we highlight items that are either coming up or are about to change, and we highlight that as well to include that the self-assessment time frame is coming up.
Yeah.
So we are trying to educate and remind.
That's good. That's good.
What is it specifically that we see that people just don't do it, that they do part of it but not all of it, that they go through and they just check a bunch of yeses and they have no idea what they've just checked yes to, so they're basically not using the tool at all? What's the feedback you're getting, Maria and or Anne, around where this tool is not working?
So go ahead,
Maria,
Anne.
would you like me to
Yeah,
answer?
go ahead, Anne.
Yeah. So Debbie, I would say that it's it's across the board, right? It's all of those things. Sometimes we find that they just have not done the inspection, or the self-assessment. Sometimes we'll find that they have, they represent that they have redone it, but from a practical standpoint, they clearly have not. They've just re-signed, and it's easy to tell even because like expiration dates have not been updated with respect to the licensees. Other times we find that they've just gone through and marked yes to everything, but it's easy to check against certain things and then know that they didn't do it because it's quite clear that they're not compliant with the provision that they have indicated they are compliant with.
This is Jig. One of the good reminders would be to put something in our PIC change form that this is a requirement as a new PIC on the application itself as a box item that whether if they are taking over a compounding facility or remote dispensing or a retail pharmacy, whichever appropriate self-assessment they are supposed to complete, that was completed when they send in the PIC change. I feel that because as a new incoming PIC, it's important that they complete it, right, the first step.
So
that's
maybe you can speak to the PIC checklist, because I believe there's a checklist of things that a PIC needs to do in addition to submitting the change form.
So I think what Jig is probably referring to is once we have approved a change of PIC, some sort of notification that reminds them. And we do send out reminders at the site-specific level, but I can't remember all of the conditions under which we do that. So I've made a note to to check in with staff, and if we're not sending out a reminder during a change of PIC, that we include that into the process.
That would be great, because I know that one of the things they are reminded about is the quarterly controlled substance audit that they should and it's not a requirement, but I don't believe it's a requirement. I think it's just a reminder to do that at the change of PIC in addition to the routine quarterly.
And the tool is great. I think the self-assessment is a good reminder of responsibility. And like Maria uses it for residents and interns, I personally have done that in my practice as well. One of the things, it's very easy to take care of a 50-page application by flying through it and just marking up yes. And again, what I'm going to suggest right now, it might not happen right away, but we should consider putting these forms online for two reasons. It could be formatted in a way where it makes them go through every question, almost like a training where, you have to kind of absorb it and a little bit of interactive, maybe a question involved, and then they check yes. That way, anybody that is completing the self-assessment, it's being recorded on the board's end as well. So it could be easily identifiable, anybody that is not compliant. And B, most of the things they're marking off, it is for, public safety and all that. And I feel that if it is measured in that way, in that manner, rather than inspector going in a pharmacy and looking for it, then it would be more effective and it will do its job that it's supposed to do. And it will generate less citations, less questions, and we will have more educated and refreshed with all the new laws and requirements that all the PICs across the California are taking over.
If I may ask a clarifying question, based on what you were just describing, are you picturing it transitioning from kind of like the fillable PDF or print and fill to more of a survey where it guides them through question by question? Is that kind of what your vision or your recommendation or suggestion is?
Yeah, we put it on our website, and it would be a link, and they would click on it, and then these questions will come on one after another. So, and then they will have the ability to print it out at the end of the session, and when they submit it, the board will have visibility on who completed it, the facility license, their license, and all the questions, how they marked it.
Are you suggesting that there would be a series of quizzes or something related to it as well?
We could add it. I mean, that is optional. If
that makes it interactive.
If I'm reading 2 sentences and I wanted to get into more detail, we could provide a link, a hyperlink right underneath that point that would take them to the law part of that would be more elaborate.
Got it.
I think actually that's a good idea, because
Yeah.
I'm looking at this, Jed. You go through it and you see the law reference. Well, that's great. Because there's probably people like some of us that actually have our law book right here handy with us. But I remember when I was in the store. I mean, I didn't. I mean, it was there somewhere, but so I think I think this is a great idea, because then you can just click on that link. You can see exactly what it says and say,
How about, since this is a kind of off topic, because right now we're just looking at the self-assessment contents, the manner of applying the self-assessment and the manner of monitoring the self-assessment, I think is a good discussion that we should add to a future meeting to agendize, to discuss the whole process, because not only is it going to be a process change that we need to discuss, we need to discuss who's going to be looking at this, staff availability and processing, within the office. Is this going to require any legislative changes? There's lots to consider there, but it is a valuable discussion.
Good idea.
So how about we take this issue of all self-assessments, manner of applying and monitoring, or those kinds of comments, and I don't know exactly how to word it, but if you staff could take that down, and we could bring it up at another enforcement meeting as a policy versus the specific self-assessment form. This one's already in the regulatory process.
Yes, I've made a note. Thank you.
Is that agreeable by the board members?
Yes.
Yeah, and actually, Maria, I'm wondering if we possibly even consider handing it over to public ed for them to tackle. Just a thought.
That I would not have a problem giving it to another committee, selfishly. But I think I guess that would be Greg that would make that decision if it goes to a different committee.
Yeah. Yep.
So make a note to discuss that further with Greg.
Absolutely. We'll do it.
Members, having reviewed the form, and aside from a couple of typographical errors that are still in it, I think the updates are appropriate and believe that we should recommend the form to the full board for moving forward. Any additional so I would like to hear a motion on something like that.
I can make a motion that we recommend to the board to accept the updated community outpatient self-assessment form with corrections as needed. Period. I don't know what else to add.
Second.
Okay, and without any further member comment, wait for a second. I think we're ready for public comment on this single assessment form.
This is the moderator. I have opened the Q&A panel for requests for public comment. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the Ask field and submit that to all panelists. At this time, our first request for comment comes from Robert Stein. And Robert, your line is unmuted. You will have 2 minutes.
Thank you. Good morning, board. I just want to mention, since we are talking about this particular document as being educational in nature, I actually incorporate this into my pharmacy law and ethics class at KGI for the very reason that students need to be familiar with the requirements. And I actually use it as a kind of a tool to check myself, because I have the students check off each of the laws that are in the self-assessment as I discuss them in class. So at the end of the semester, they all turn their assessments in, and I can see where either students missed what I taught or that I failed to teach a particular topic. So again, I totally support the use of this form in practice and in education. Thanks.
Thank you.
Our next request for comment comes from Stephen Gray. Stephen, your line is unmuted. You will have 2 minutes.
Thank you very much. I also use the forms quite extensively in the pharmacy law classes and recommend them highly to people who are not only getting ready to take the California law exam, but also are coming into California because the form identifies things in a way that they think they know what the law is, but when they come into California, they find out that it's a little bit different, or there's an interpretation that they weren't used to. So I think they're very helpful. Regarding their length, I don't think that's a problem for the users. It is a problem for the reviewers. And I've found in the past that a lot of people, maybe even board members, simply don't have the time to review all of the details that they're being asked to approve. I understand that the next step in this, and please correct me if I'm wrong, is they go forward through the regulation process, and there will be again time for public comment on that. And I look forward to having more time to review the changes and the contents than we have today. Thank you very much.
Thank you, Dr. Gray. Anne, maybe you could respond to where this specific form is in the regulatory process now that we're adding additional changes.
Dr. Gray is correct. There will be an opportunity for public comment. I believe the board's counsel can provide additional specificity to that process if the committee so desires.
And this is the moderator. At this time, we have no additional requests for public comment. Would you like me to close the Q&A panel?
Please do. Thank you.
It is closed.
So we're going to vote on the motion to take this for approval to the full board, this one form. Did someone want to speak? Okay. Let me call for the vote. Greg Lippy?
Yes.
Jig Patel?
Yes.
Ricardo Sanchez?
Yes.
Debbie Veal?
Yes.
Albert Wong?
Yes.
And I vote yes also. Motion passes. The next self-assessment for our review is Community Pharmacy and Hospital Outpatient Pharmacy Compounding Self-Assessment. It is my understanding that the staff are recommending to pursue regulatory change to replace the current version, which is from 2012, to this new proposed version included in the meeting materials. It is my understanding that when the board updated its compounding regulations in 2017, the self-assessment form was not included in the rulemaking file at that time, and no subsequent rulemaking was pursued to update the self-assessment form to reflect the regulatory changes that took place at that time. And that was in 2017. Since new regulations took both effect in 2012 and the draft 2016 versions have been online. So essentially this is a new form. So I will not be highlighting the changes, and you will note that with all self-assessment forms, the legal citations are included. So this is, as it says on the slide here, a repeal and replace, and the document is in the meeting materials. So I believe that the proposed self-assessment form is appropriate, And since it's not pending regulation to replace the form, I think we have an opportunity to have our legal counsel, Miss, and I'm probably going to pronounce this wrong, Miss Tatian and Miss Smiley, can you confirm that the self-assessment form would be appropriate to start the rulemaking process? Is there anyone available to talk to that point? Since we're doing a repeal and replace, our motion needs to include starting the rulemaking process.
Hi, this is Eileen Smiley. I was waiting to see if the board's counsel for the rules was on, but I don't hear her on the call right now. So I think it would be proper to start the repeal, to put that in the vote, because this would be a repeal and replace, which means we'll go through the comment period and commenters would get a chance during the rulemaking process to comment on the complete form.
Thank you. So it sounds like we do need a motion to recommend to the full board the approval of the self-assessment form and to initiate the rulemaking process.
So moved.
I'll second.
Is that Debbie?
Ann, and
Yeah.
okay.
Yes.
Okay, go ahead, Ann.
Moderator, the board's other counsel needs to be promoted to a panelist.
Oh, there she is.
Thank you.
So that's what happened. So Ms. Tatian, did you want to add any additional information before we start our board discussion?
Thank you. This is Sheila Tatian. I hope you can hear me. I don't have anything to add, but the process is correct. If you have any other questions, let me know.
Great, thank you. So I'm asking for a motion. Oh, we had a motion and a second. So is there any board discussion? Hearing none, we're ready for public comment.
This is the moderator. I have opened the Q&A panel for requests for public comment. If you'd like to make a public comment, please click on the Q&A icon on your screen, type "I would like to make a comment" into the ask field, and then submit that to all panelists. We will pause for a moment. We have a request for public comment from Paige Talley. Paige, your line is unmuted and you will have 2 minutes.
Great, thank you. Paige Talley with CCAP. I have a clarifying question on, let's see, of the draft. It's page 16 of 24, and the number is 17.11. I do remember some discussions of raising the Fahrenheit or Celsius rather than keeping it as it was, but I'm just unclear. So because CCR 1751.4K says 20 degrees or lower Celsius, and this says 20 to 24 degrees. So you are raising it and you're amending CCR 1751.4K, correct?
What page are you on? Is that 17, did you say, or 18?
I'm looking at page 16 of 24 of the compounding assessment.
We certainly could double check that, but the self-assessment is taking in light current regulation. So those regulations were updated twice in the last few years. But we can certainly double check to assure that the self-assessment accurately portrays what's the regulation.
Okay, thank you, because I did look in the law book, and the law book reads everything identical to what 17.11 is, except it says a room temperature of 20 degrees Celsius or cooler.
Okay, thank you for pointing that out. We'll
Sure.
check to make sure that that is correct in the self-assessment.
Okay, thank you.
Seeing no additional requests for comment, would you like me to close the Q&A panel?
Please do.
It is closed.
Thank you. I think we're ready to call for the vote. And as the motion as previously stated, Greg Lippy,
Yes.
Jake Patel,
Yes.
Ricardo Sanchez,
Yes.
Debbie Veal,
Yes.
Albert Wong. I'm sorry, Albert, was that a yes?
Yes.
And I vote yes also. Thank you. The next self-assessment form for our review is the hospital pharmacy self-assessment. This is very similar to the first one we discussed. It's my understanding that some changes of clarity, along with changes to incorporate changes in that's a lot of changes in the pharmacy law. Rather than go over each individually, the changes are detailed in the meeting materials and on a summary slide. So if you could post the summary slide. This self-assessment is already going regulatory review. So these would be additional changes to add to the regulatory package. Can we go to the next slide? There it is. Thank you.
Maria, I'd like to make a motion similar to the one I did for the community pharmacy that we recommend to the full board to accept the updated hospital self-assessment form.
Thank you, Debbie. Is there a second?
Second.
Any member comment? Okay, we're ready for public comment.
This is the moderator. We have opened the Q&A panel for requests for public comment. If you'd like to make a public comment, please click on the Q&A icon at the bottom of your screen. Type "I would like to make a comment" into the ask field and then submit that to all panelists. We will pause for just a brief moment.
I don't.
Seeing no requests for comment, would you like me to close the panel?
Please do. Thank you.
It is closed.
So we're ready to call for the vote on the motion as previously stated. Greg Lippy? Can I unmute?
Yes.
Thank you. Jig Patel?
Yes.
Ricardo Sanchez?
Yes.
Debbie Veal?
Yes.
Albert Wong?
Yes.
And I vote yes. Motion passes. As a reminder, we will not be discussing the last two self-assessment forms at this meeting. We will wait for the completion of the current regulatory review before adding any additional changes. So we're going to move on to the next item on the agenda, which is number 7. There we go. Discussion and consideration of proposal to develop an alternative enforcement model. Members, the chair report details out relevant provisions of law, and as you may recall, in July 2020, we received a presentation on the administrative case process. As was shared during that presentation, the administrative case process has 2 fundamental guiding principles: due process of the respondent and public protection. As Deputy Attorney General Jarvis reminded us, the state has a duty and a responsibility to ensure a licensee is competent and trustworthy. More recently, during our October 2020 meeting, we continued our discussion on an alternative enforcement model. The committee did not reach a conclusion, but determined that additional consideration of the overall policy goal and what, if any, proposed solution would be appropriate. So that's what we're doing today. The meeting materials include statistics we previously discussed. I believe it's very important for us to make a decision based on this data as opposed to responding to anecdotal information. At our last meeting, we agreed to take a step back and consider some larger policy questions. Staff have detailed some questions in the meeting materials, but there may be other important issues that arise during our conversations. Included in the meeting material is the previous guidance council provided members regarding the previously proposed model. In Ms. Smiley's memo, she noted that a licensee that wants to challenge the factual matters or the application of law to the facts should go through the process under the Administrative Procedure Act. That's via a judge. An alternative process is not possible under the current legislative authority. Ms. Smiley also raised a number of concerns about the potential for preliminary hearings, including evidentiary issues and Open Meeting Act considerations. To me, the most significant issue was with the previously discussed alternative hearing model was the admissibility of the record if settlement is not reached. Ms. Smiley noted that in some instances, legal issues could arise if settlement is not reached, and it goes through the full administrative procedure after the fact. She also pointed out that a pre-hearing runs contrary to the stated goals and could result in additional costs if 2 hearings on the same matter are heard. There were also some additional issues that arose with the suggestion that board members participate in the settlement process. As noted in the meeting materials, it appears to be most problematic when board members are included in the pre-hearing component of the process that was suggested. During our previous discussions, there was concern that respondents may find it difficult to navigate the administrative case process and result in additional delays. As a reminder to all of you, the full board agreed to publish informational tools in the form of FAQs and a flow chart to publish on the board's website, and to request that the Attorney General's office send out to all respondents these tools to understand the process better and their rights. That was a lot. We've gone over quite a bit of history of the discussions because this has been a difficult discussion over a little bit of time, and there were some problems in the previous suggestions, but we need to move forward and have a productive discussion. So before we hear from members of the public, let's see, let me go back and read this again, just to make sure I have this in the right order here. Let's hear first from members of the public. After public comment, I suggest we organize our committee's discussion to reflect the public comment and to review the questions in the chair report, which is in page 6 and 7, if you want to pull that up. So I'm suggesting a little bit of a backwards discussion, but I think that we need to hear from the public so that the members can have a good discussion, not only of our information, but to incorporate public comment. So do the members have any questions about that? Is that amenable to all of you?
Fine.
I think that's,
I'm fine with
that
it.
sounds good. I think we just encourage the public to talk to those questions. So I think, the questions that you as a staff has developed are key. And so to have them talk specifically to those questions would be helpful.
Great, I appreciate that. Thank you, members, for your consideration. As we open this up to public comment, I would ask members of the public, and this is important, to refrain from speaking on any case-specific information. This is in part to preserve the board's authority to act on pending matters in the future. Further, I caution members that at times when we receive public comments that reflect individuals' opinion of events, that may not be consistent with the public record on the matter. So we're going to, moderator, we're going to open up for public comment, but I would suggest that we start with Danny Martinez. So I wanted to let, as you get him queued up, I wanted to explain why we're starting with an individual first, because I'm aware that we have received a proposal from CPHA on this issue. And as we open up for public comment, I believe starting with a representative from CPHA, who I believe is going to be Danny Martinez, would be helpful. CPHA has submitted information that is available in the meeting materials. While we are limiting comments to 2 minutes, we may provide some minor flexibility if necessary for all public comment. I ask that Mr. Martinez limit his comments to the CPHA proposal only, which meets the 2-minute time frame. And to assist him, While he's speaking, we will actually display a slide that is the CPHA proposal. So moderator, if you could go to the next slide. I think we're ready for Danny Martinez's comments.
This is the moderator. Mr. Martinez, I'm unmuting your microphone, and you may begin when you're ready.
Thank you very much. Danny Martinez with the California Pharmacists Associations. Thank you to Chair Serpa for this opportunity. As has been thoroughly discussed in several meetings, this is a very important thing that we're trying to work on. And so my comments are going to be limited to, as mentioned, this proposal. What you'll see is this is a proposal that was actually proposed by the board in July of 2019 with my colored additions and subtractions, strikeouts to that. The reason I'm submitting this proposal is because this proposal was submitted back then, and I don't believe there was a full discussion on this specific proposal. And there's a lot of changes and a lot of strikeouts, but the main idea behind this proposal is that as licensees are charged with an alleged disciplinary violation or a violation that results in disciplinary action, at no point in that process, and I explain this in the other slides that I have in this presentation, but I'll limit it to this. There is no opportunity if the inspector or if a board staffer who has formally accused a licensee of something that rises to the level of disciplinary action, there is an opportunity to correct information that may or may not be faulty. And this is meant to say that, you know, we're all humans, inspectors included, we make mistakes, and this is not a dig or an insult to inspectors, but the idea is that we all make mistakes, and they do happen. They don't happen often, and we're not saying that it does happen often, but they do happen. And in those cases, it would be extremely helpful for the accused licensee to be able to correct the record, because under the current process right now, the first available opportunity for this licensee to say that there's been a mistake that's been made is in front of a judge, and it is after they've hired an attorney and after they've spent money essentially preparing their defense.
10 seconds.
In the interest of fairness and in the interest of trying to minimize the time it takes for this to happen and for the costs associated with the licensees, we'd ask for your consideration of this proposal, and I'm happy to answer any questions you may have.
Thank you, Danny, for your comments and for your presentation that is in our meeting materials should any members or public members want to review it. Before we move on to other public comment, I wanted to give an opportunity for members to ask any clarifying questions of Mr. Martinez.
Maria, I just have one. So I don't think that the first step is to go to the in front of the judge. I was thinking you could also do a stipulated, you could enter into the understanding of a stipulated settlement, and in that you would be talking with the staff of the board, and if there were these errors, I would think that it could come up there, and then if the licensee does not like the response from the board staff, then it could then move on to the administrative law judge. So I guess I'm thinking, don't we, I mean, isn't in the stipulated settlement step, couldn't this, the revelation of possibly some errors by the inspector or the board, couldn't that come up at that point in time?
You're correct in that we had discussed all the steps, because there are many different steps, and that's one of the tools that we agreed to at our last meeting that's going to be published, is a visual diagram and an FAQ that explains all the opportunities for interaction with board staff before you get to a judge. And then some of it is required by legislation, certain processes. But perhaps Anne or someone from the staff could respond to your specific question about the process for stipulated settlements.
This is Anne, and what I would like to, I think, kind of reiterate a little bit is, as part of the investigative process, it is an interactive process. And, you know, the board is responding to information both that we have identified as well as information that has been received by the licensee. So it is an interactive process. In addition, as part of the investigative process, we issue a notice of violation and we provide the respondents, again, an opportunity to provide additional information in response to the in response to the notice of violation. So again, it really is intended to try to get all of the relevant information, both what we observe and identify, as well as additional information from the licensee through the investigative process. Once it is referred over to the Attorney General's office, there is again opportunity for interaction. The board is represented by the AG's office at that point. And then the licensee is either working directly with the AG's office and or through their attorney at their decision.
And to clarify, an attorney is not required, correct? Anne?
Yes, that is correct. Sorry, hard time getting the mute button.
Okay. Any other clarifying questions for Mr. Martinez regarding his testimony? Okay, hearing none, let's open up to other public comment. And moderator, can you change the slide? I think I agree with Debbie Veal's comment that maybe we should show the first 5 questions on the screen as we're hearing public comment. So members of the public maybe have the opportunity to use our questions that we are going to consider in their comments should they desire to include them. So can we change the slide?
And as you're waiting for that slide to change, I just kind of want to make one follow-up comment. Danny, I hope you heard, you know, kind of what I said, and I think what Ann said also, that we actually are interested in trying to address those situations where there's maybe an error in the board assessment and or, you know, so it's not that we're not hearing you. We think that we have, that the licensee has the ability to do that today.
So moderator, is there an opportunity to change the slide?
Yes, we are putting it up now.
Thank you. And we're ready for future public comment. Thank you.
Okay, we have opened the Q&A panel for requests for public comment. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the Ask field, and you can submit that to all panelists. Our first request for comment comes from Joe Grisella. And Mr. Grisella, your line is open, and you will have 2 minutes.
Okay, thank you. First of all, what Debbie suggested, it just doesn't happen. You are not able to go in front of a pharmacist and speak and tell your side of the story. It just does not happen. You could send in some information, but you cannot orally discuss this. And sometimes you may be speaking to someone who does not have the knowledge, especially in something like compounding, the most complex division of pharmacy, and they just don't understand. So that's why you got to have it orally and point out in the law why you're right or why this should not proceed. So this doesn't happen. And that's why we need this, and we need board members to be able to see this and to have oversight so that they can understand and transparency that this is being done fairly. But you do not have a chance to go in front of, you do not have a chance to go in front of the board or an attorney general. They just send you directly to administrative board, which costs you $100,000 just to get to the first level and another $200,000 to get to trial. Now you should be able to come in front of the board like Danny's suggesting here and all other boards and plead your case. It's going to take 15 minutes. You make your decision, and most likely 95% of the people will accept what you say because they don't want to spend the $300,000 to go in front of the judge. So, but if they wish to, They can, but nobody's going to do this. And I've done a lot of research on other boards. 98% of the cases are all solved right here with this program. And we just don't have that. And it's really not fair due process. And if this were happening to you, I think you'd think a little bit differently because you just can't afford
10 seconds.
This money.
Okay, thank you. Maybe Anne and Ms. Smiley, if you'd like to respond to some of the statements that were made to assist us in determining the validity.
Yeah, and because, or Ms. Smiley, because it seems like we have a disconnect here. I think we think that something is happening, and based on Mr. Graziella, I think I had your name right, Joe. Sorry. It seems like we have a disconnect. He seems like he's seen it one way, and we're describing it a different way. And what he's describing, I think, is what we don't. We are trying to be open here.
And I think one thing to consider, Anne and Ms. Smiley, in your comments is what is the most common response versus an individual's experience in potentially one case, or speaking to the larger issue and the number and the vast majority of people who undergo the process. If you could speak to those people or those situations.
So this is Anne, and I think what I would say at the beginning is that I think that Ms. Smiley has already expressed concerns about some of what was suggested by the previous commenter about board member engagement at the front end, the challenges that could potentially arise legally from a pre-hearing kind of conference or whatever you want to call it. I believe that there have been significant legal concerns raised with that have been previously brought forward. I believe that in addition, I believe that the process is consistent with how I described it, with interactions and the opportunity for licensees to speak with people. I would also just kind of highlight that our inspectors are all licensed pharmacists that have on many occasions been determined experts in even through the courts, through cases, and have been determined as experts. And as such, when they are doing the investigations, they are licensed pharmacists that courts have found to be experts. And I think I'll just leave it at that.
Ms. Smiley, do you have something to add?
The only thing that I would add is it seems like the commenter, is saying that currently they don't have an opportunity to get before board members prior to that, and that is accurate. But I think what Anne is saying is that they have the opportunity prior to the accusation being filed to meet with the staff or to give other information to the staff to try and correct if it's faulty information. I don't know if that means that, the staff made a mistake in interpreting a form, or they have disagreements over the actual facts of the case. I just don't know what's meant by faulty information. But if it's saying that maybe the staff interpreted something incorrectly or didn't get the right form from them, that could be faulty, but that could be brought to the staff's attention. But currently, he is absolutely correct. There is no process for them to get before the board members or any part of the board at that time.
But Anne's comment was that staff members include pharmacists who are experts in the field.
That part is absolutely correct. And so there is the opportunity, I think, and possibly Anne could answer that, is there opportunity after the investigation is completed just to submit information, or can they also meet with the board staff?
So typically it is done in writing. However, there's, when we're on site doing inspections and everything else, of course, that is all oral. Yes, there is opportunity through the notice a formal opportunity in addition to through the investigative process. When we issue the notice of violation, I believe that we specified, 14 days to provide any additional information, responses to the notices themselves. So yes, there is opportunity both through the investigative process as well as after. And then I would just remind members that when you, as the decision maker, vote on items, you receive a record of the information so that you have information before you, not just the stipulated settlement or the proposed decision. The proposed decision is going to include facts of law and findings of the judge. A stipulation doesn't go to that level because there is no administrative law judge, but you similarly are provided with a record to review as part of your decision making.
Thank you. I think I just had a couple more comments on there that maybe we could provide some more information. Is that the because of the confusion as to opportunities to engage and timing to engage, that was one of the reasons why our committee and the full board approved the FAQs and a document that specifically will go out to respondents, showing them the process and their rights. And so there are opportunities and rights that are well before appearing before a judge. Am I stating that correctly? I just want to make sure I'm stating it correctly, Anne.
Yes, I believe that's correct.
Okay.
I have a question for Anne. Anne, if an inspector gets it wrong out in the field, does the pharmacy or pharmacist have the ability to discuss it with another pharmacist, another inspector, to get another opinion or not?
I would say that the investigative process, Greg, is pretty formal. But what I would say is that it is not a single inspector that is evaluating all of the information. The inspector will write up an investigation report. It is then reviewed by another, by a supervising inspector, who again is also a licensed pharmacist. And then any case where there's the potential to go to referral to the Attorney General's office, then goes through another layer of review as well. In addition, once the matter is referred over to the Attorney General's office, if you recall from Christina Jarvis's presentation, the AG's office independently does an assessment of the case, all of the evidence, to determine whether or not it is appropriate. If you look at our data with respect to cases, very few are rejected by the AG's office. And I believe part of that reason is inherent in the fact that we have so many controls in place with respect to our investigative and review process.
But all of that is in writing. It's not it's not the person who's being accused or whatever the proper word is. It's not them having the ability to sit and discuss it with the supervising inspector or with the AG's office, from what I hear. It sounds like it's all in writing. Is that correct?
So, Greg, yes, so as the investigative process, right, you're asking questions, you're receiving information, but from an evidentiary perspective, you don't ever want to be in a position of a he said, she said, so you get it documented in writing. So whether that's through a declaration, rather that's through questions and answers. So it is an interactive process, but as you hear, even, during committee meetings and things like that, two people can hear the same thing but have different perspectives on it, right?
Right.
And so that is why it is done and documented in a paper form.
So just to clarify, though, too, in the beginning, before it is a written item for potential discipline, during the inspection process, there is a lot of communication between the individual and the or the pharmacy itself and the inspector to investigate and evaluate and determine. And that's pretty much done verbally while you're on site with the investigative process. Is that correct?
Well,
I think some of it is verbal. I think some of it is observation, and I think some of it is through documentation.
If
So
somebody,
it's a combination, and I'm wondering if it would be helpful for this committee, and I'm not trying to hijack this discussion, so I'm apologizing, but would it be helpful for a presentation on the investigation process?
You know, it might be, Anne, because I think part of the question is way back there at the beginning when you said the inspector goes to the store or whatever and comes back and says, I think I have a case. And you said then, like the supervising inspector or someone else would look at it. So it seems like at that point, there's now two sets of pharmacist eyes looking at it. And these people are going to be experts, I would think, in this area. And if they aren't, they would probably call in the expert. And so at that point, it seems like we do a good look to make sure that no one's done the oopsie or misinterpreted anything, you know, just kind of internally. And then the next chance for I'm going to just call it the oopsie to come up is, you know, when we ask for information from the licensee, and I agree, it has to be in writing, because if it's verbal, that just doesn't work. But in the exchange of communication, emails or communication, it seems like once again, you know, the oopsie could also be found at that point. I mean, I totally agree with what Ms. Smiley provided us. The threat of, you know, having some board members involved then removes those people from ever being able to, you know, we have to recuse ourselves from the case. And, you know, I think we'd like to have everybody on the case that we possibly can, because I think it actually benefits the licensees to have all the different perspectives. The board's made up very thoughtfully of various people, and so to all of a sudden have to remove those people, I think is a problem. So I do agree with her. Anyway, it feels like we have multiple options, both internally and then from the licensees, to point out the oopsie.
So I think we, just to clarify, we were just commenting on Mr. Grisella's public comment. We're still in public comment. We're going to have lots of opportunity. I'm sure we're going to have lots of board member comment. So is it okay to kind of put a pause on our member comments?
Sure.
If they're beyond the scope of Mr. Grisella's question. The other thing, as I see in the chat, and so I want to ask the committee, is Daniel Martinez points out that he didn't get a chance to respond to Member Veal's comment or question. So what is the feeling of the committee to allow Danny to respond to Member Debbie Veal? Yes. Or does Debbie have any comments about that?
I would welcome,
I'm okay.
I would welcome his response.
I'm okay with it.
Let him respond.
So we're so I apologize. We probably should have done that before the second comment, but moderator, maybe you could assist with Danny Martinez being able to limit his comments to Debbie Veal's question.
Absolutely. Mr. Martinez,
Debbie, do you know what your question was? Can you repeat it? Or are you okay with Danny just interpreting it?
Yeah, I'll let Danny, I'm sure Danny knows what my question was, and I trust him to tell us what it was.
Thank you, and I apologize, Mr. Martinez.
No, that's okay. And actually, if the moderator could put my slide back up, because her question was on one of the things that was in there.
Co-moderator, can you go back to the public comment slide that we used during Mr. Martinez's presentation, please? Slide 25. Thank you.
Yes. So, Debbie, your question was, you had asked her if there was an opportunity to speak from the licensee point of view during a stipulated settlement. And so in the first paragraph of this proposal, right where it says may offer and a licensee may accept, where I write either a stipulated agreement to licenses when That phrase right there, a stipulated agreement to license discipline, this is why we are concerned about this. This stipulated agreement that you were discussing or referring to, the answer to your question is no. The licensee doesn't have that opportunity, because going into that discussion on the stipulated agreement, the baseline is we are going to discipline you. How severe we're going to discipline you is dependent on whether, what you say or what you guys have to say and what we have to say back to you. So that part right there is where we find the problem. This is not a situation where two parties come in and say, okay, let's figure out if you actually did violate the law. There's already, and this is why I keep saying, there's already an assumption of guilt, because when you enter that conversation, the law, as it would state, or as was proposed earlier by the board, stated that there was accept a stipulated agreement to license discipline. That phrase right there was problematic. That's why I added after that, or an opportunity to provide mitigation evidence. So I just wanted to respond to that question that you had of whether they can do this at the stipulated agreement, and I'll limit my comments to that.
Thanks, Danny.
Thank you. So I think we're ready to move on and complete public comment. So I apologize, we're kind of jumping around a little bit here, but I think we have an additional public comment.
We do. Our next comment request is from Rachel Israel. And Rachel, your line is open and you will have 2 minutes.
Hi, thank you. I actually responded that I'm going to withdraw my comment at this time because it's been addressed by some of the discussion that happened in the meantime. Thank you.
Thank you. Next request is from Robert Stein. Mr. Stein, your line is open and you will have 2 minutes.
Thank you. Robert Stein from the KGI School of Pharmacy. I teach pharmacy law and ethics and am both a pharmacist and attorney. I want to speak in support of the modifications to the language that CPHA has proposed. The previous language is highly prejudicial just in looking at those words. These are allegations at the point until the end of a proceeding when due process is completed. And it would seem if it's a substantiated violation of law, that's making a judgment prior to the opportunity for the accused to respond. So again, I just want to strongly support those specific changes that talk about moving from substantiated to alleged. Thank you.
Thank you. And I think that in future discussions, it might be helpful for us to have the materials that were presented by the AG's office, because I think just to clarify, if you look at the flow chart, the stipulated settlement is an opportunity, but it's not a requirement. The individual can go further to the next step, which is arguing the case. So that's all I think I want to say about that. We have additional public comment?
We do. Our next request for comment is from Paige Talley. Ms. Talley, your line is open and you will have 2 minutes.
Okay, thank you. Paige Talley with California Council for the Advancement of Pharmacy. I'm in support of CPHA's modifications. And I just want to say that also, we talked to, someone mentioned, I think maybe it was Anne, mentioned that the AG's office is unbiasedly or looks at a potential case. But, the AG's office, by its very nature, is a prosecutorial agency. So I don't know how unbiased that is. I also think that I agree that, Ms. Smiley said there were some legal issues, but perhaps you can get around those. I just think it's really important for pharmacists to get before someone else, and maybe it's an advisory committee. I think Danny brought that up a long time ago, and maybe that could be an advisory board. They could meet with them, and that takes the Board of Pharmacy out of it. And you could comprise that of perhaps, I don't know, this is just off the cuff, but previous board members. I don't know, but I'm aware, and I can only give you anecdotal information, which I know you don't want, but there are challenges, and this needs to change. Thank you.
Our next request for comment comes from Rick Rhodes. Mr. Rhodes, your line is open and you will have 2 minutes.
Yes, thank you. I appreciate the opportunity, and I thank the committee for discussing this matter. I have one comment and I guess a question as well. I was a witness in one of these types of hearings with the Texas Board of Pharmacy. It was a panel that included board members. It was a very productive discussion and also very clarifying. So I just want to say I was a part of one of these types of hearings in Texas, and I think it went very well and was very helpful for both sides. The other thing would be a question. I believe Josh Room did a presentation on this in 2018 about the whole disciplinary process. It was a very good presentation, but he said something, and this is the question. I believe he said that the respondent is at a major disadvantage when it goes to the Attorney General's office, and that throughout the stipulated settlement agreement, the respondent it's not a 50-50, it's not equal. The respondent is at a big disadvantage, the accused. And I believe, and this is where it's a question, I don't want to make the statement that it was either Josh Room or someone else said that the default position of the board during that stipulated settlement hearing is revocation. That is the default position. So, as a licensee, as a pharmacist or a technician, whatever it may be, you're faced with revocation. That makes, negotiation a pretty difficult thing to do. So I'd be open to correction on that, but that was my recall from that discussion in 2018. Thank you.
And our next request for comment comes from Stephen Gray.
Oh, I'm sorry. Before we go to Stephen Gray, maybe Ms. Smiley could respond to the comment of quote unquote default. Default is probably a different word, but about the reason why it's revocation and revocation with probation. Maybe you can explain that process, because I'm sure what he's stating was probably meant in a different way. And so a legal opinion would be good, or discussion.
I'm sorry, I'm having a hard time understanding. Was he saying that they're at a hard time in the negotiation because, with the disciplinary guidelines, depending on what is alleged, you'll have a range of potential disciplines for the different category. But people can always, I think, as part of the stipulated settlement, either argue, for something else within the range of the disciplinary guidelines, or argue something for some other penalty. But that's obviously open to the agreement of both sides.
I think what he heard, because he used the word default, when there is a default, which means that the person did not, file a defense, or the person did not appear when they were supposed to a hearing. When there is a default, our hands are tied. All we can do is revoke when we're making a decision on a case. Maybe that's what he was referring to, as opposed to the context in which he stated it.
Right, and I just wasn't sure, Greg, which way he meant it. It seemed like in the comments, or maybe if we could get clarification from him on what he meant. It seemed like with his comments to me that he was saying the AG's default position is that we're going to revoke the license, or maybe he was talking about the default judgment part of a case.
Well, and I think that's part of the problem, is he was trying to recall, and he said that he wasn't quite sure. But I think that what Greg stated is may be, because that word default has a legal definition for us lay people, was something to learn for me on the board, is that a default, like as Greg stated, it means that there is no argument from the respondent. They are not providing any evidence or applying to the process. And if we don't hear anything, the board's only response is to revoke.
No, I think that would depend. I'd like to hear what the Deputy Attorney General would say, but I don't know if they're in this call. I think it would depend how the accusation is phrased. So if somebody doesn't make an appearance, and that's what usually happens, they don't respond in any way, then we'll go with the default judgment. I think it's dependent on how the accusation or the statement of issues is pled. But then, as you know, if somebody does then want to challenge it, the board will usually entertain a request to set aside the default judgment.
Correct.
The person a chance, or the pharmacy a chance to respond to the allegations.
That's true. Yeah.
Correct.
If I can also just clarify that in an administrative action, the board has the burden of proof to support the allegations that are contained in the accusation, and the level of proof that has to be, and I'm not an attorney, so I'm using all the wrong words, but we have to meet a very high standard, especially for professional licenses, and it's clear and convincing. So we have to we have to meet a specific bar in terms of the level of proof to be successful in an administrative matter. And perhaps Eileen wants to just speak a little bit about the burden of proof, because it feels like it runs a little contrary to perhaps what the last commenter was speaking about.
And Ann is absolutely correct. As you know, we have the burden of proof. So I have problems when people say that, there's an assumption of guilt. There isn't. We can't, the board cannot discipline a license until it meets its burden of proof, unless somebody defaults and doesn't answer an accusation or a statement of issues. And I believe the Attorney General's office, when it's evaluating cases sent over for referral, will also look at the evidence to see if they believe there is a good faith, basis for them to meet the appropriate standard, the appropriate burden of proof, but before they go ahead with the filing of an accusation.
Mm-hmm. And just to add to that, this was at a previous meeting where we commented that during this entire process, the licensee maintains their license until the process is completed, unless there is, I forget the legal term, where there's some sort of like injunction or comment filed that removes their license immediately. But typically, the person is practicing and licensed throughout the whole legal process.
Unless there's a cease and desist, right?
That's the word.
Okay.
Okay. Let's move on. I think you said Steve Gray was our next comment.
He is. Mr. Gray, your line is open and you will have 2 minutes.
Thank you again very much for the opportunity to comment. We again, speaking on behalf of CSHP, first of all, I want to compliment CPHA for going forward diligently over many years to try to get some resolution to the problems and a better way of doing things. We are concerned that the discussion has only focused on the of what has been proposed. The opinion from council indicated that to achieve time and cost savings was the purpose, and we haven't heard enough about the positive opportunities that an alternative has meant. I can tell you that in working also with other boards of pharmacies, being a compliance officer for over 600 facilities for a decade, there are plenty of opportunities to save time, save money, and come to a better conclusion. The essence of what's been talked about is there's an investigation of facts. And what we often hear is a problem not with the investigation of facts, but with the application of law to the facts, the way the inspector or the supervisor inspector has interpreted. This alternative would provide an opportunity to go before members of the Board of Pharmacy who determine policy and interpretation and speak their mind and say, hey, the facts are do not indicate a real violation of law or board policy, and let that be heard. This is going to become more and more important as the practice of pharmacy becomes more and more nuanced into the clinical areas and the management of medication, where you cannot set everything out in so-called black and white regulations or even self-assessment forms. And I think that if the board really needs to step back and say, what are the good parts that could come from this, even if we have to change the law? We've already seen that the physical therapists and others have considered alternative processes. And if it means changing the law and in the best interest of the public, we can expedite things and not have so much delay or expense that drives access to pharmacist practice or pharmacy operation out, then that's a good thing, where everybody gains from the process. So I would encourage the committee to go back and say, let's look at, to accomplish this, what we can do. And I also know that, unfortunately, there is an inherent bias in the supervisor inspector. They want to support their inspectors. I know many of the inspectors, they're great people, they're well-intended, but they are not at the level of being able to totally be unbiased about everything that comes before them, or to adequately interpret all the application of the law to those situations consistent with board policy, which is more and more relying on pharmacist judgment as to the actual situations. Thank you for the opportunity.
Thank you, Dr. Gray.
Our next request for comment comes from Chris Gavant. Chris, your line is open and you will have 2 minutes.
Thank you so much. I really appreciate the opportunity to talk and that the board is listening to this conversation. I too support CPHA's proposal for the modifications. And as both Daniel Martinez and Joe Gracella mentioned earlier, these inspectors are human. Errors can be made. And when I say errors, they can just be an oversight, not necessarily a misinterpretation. During these investigations, there's a lot of requests for documentation, and it can be volumes and volumes and volumes of information being sent over to an inspector. And things, as a licensee, you just have to assume it was received, it was seen, it was read, and that's all we have. There's no information coming back that yes, we got this, this, and this. So the accusation comes, and then it's too late to correct anything that may have been an accidental oversight on an inspector's side, and it hits the administration board, and this is kind of where the degrees of discipline happen, and the licensee loses their ability to make the correction if there was an oversight or an error, an accidental error. And as it's been mentioned, it is a wildly, extremely expensive process, I think, for everybody involved, including the board. So if we had that step where a licensee could talk to members of the board, correct anything that may have been missed or not seen, or just an oversight, we could stop some of these scenarios from possibly happening. And I'm grateful for you guys taking the time to listen, and that's all I have to say today. Thank you.
Thank you for your comments.
And with that, that's the last request for public comment. Would you like me to close the Q&A panel?
Please do.
It is closed.
So taking in consideration public comment and some of the questions that board members may have, this is our opportunity for board members to comment. In addition to the policy questions that we have an opportunity to discuss, there are actually quite a few things here. So there are 10 questions, and I'm hoping we do not have any time constraints, but if this continues a little bit longer, we may take a lunch break before we finish this agenda item. I look to the board if that's going to be appropriate, but we'll see how we progress. I don't want to shorten the discussion at all. Rather than go through all 10 questions one at a time, I think we've discussed different parts of them, and some of them kind of go together. So on the screen now are the first 5, and then we could talk about 6 through 10 more individually, because that's once we decide what steps may be required, we could talk about what is possible. So if that is helpful, I don't want to limit the discussion, and there may be other things that are not in the policy questions that you wish to discuss. So I'm opening up to board member comments.
Maria?
Yes, Albert.
Yeah, can somebody clarify why the pharmacist sit on the hearing that cannot be participate in the voting?
So perhaps Ms. Smiley could respond to her memo. In the meeting material, she detailed the legal arguments and concerns. So if you want to pull that up too, Albert, you can pull to that page and then she can comment on some of that.
And part of that, Albert, is generally what we try and do under California's law. There's rules when you have to recuse yourself, including we try and keep separation between who's involved in the prosecutorial and who is in the adjudication. So if you have somebody, say you and a professional member sits on this committee, and then you get evidence that is submitted to you or comments that are made that are not part of the official record later, if we don't come to a hearing, then you've participated in the process, so you would be recused from that. It's no different now that sometimes board members might be consulted on, something, or the president might, and if they do that, then they recuse themselves from the case. The same way as with me, if I'm going to advise the board in its adjudication role, then I don't participate in the prosecution of the case as well. And so there are some times if I have to help the Board of Pharmacy with a question, then I may have to recuse myself if it comes up before the board.
Okay.
So just to bring everyone's attention, so this is attachment 4, which is Ms. Smiley's detailed memo of her concerns. I summarized the concerns in the chair report, but if you wanted to look at the details, it's there.
Yeah.
Go ahead, Albert. You have a few other questions?
Yeah. Well, before we have 7 or 8 board member participating in the board decision, we have problem with the quorum. But now we have 11. So I think if we have one less, I think we have 10 to make those decisions. I think it's probably doable.
So, moderator, if you could stay with 1 through 5, I think we're not going to move on to 6 to 10 until the next step. Thank you.
So, Maria, this is Debbie, and I'm kind of reflecting on some of the comments that we heard. And I guess a lot of my reflection is I'm looking at the California Pharmacist Association proposal that you had up earlier. And I guess I have a couple of thoughts looking at this. Is there a reason, and this is probably Ms. Smiley, you can answer this, is in a lot of the, I think Mr. Stein, Dr. Stein referred to this, is throughout it says the substantiated violations as opposed to alleged. And is it substantiated because we have gone through the process? And it's been substantiated by the board staff. Is it, I mean, so I guess I'm just asking their request to change substantiated to alleged. I'm just interested in your comments.
I think at this point, what their proposal is making changes on something I think that was originally proposed. It's not currently the law. So I wasn't here, obviously, when the first proposal was made, so I don't know why it was drafted the way it was, but I think it's important to note that this would be changing, unless I'm mistaken, what he's put up are his proposals and changes to a proposal that was introduced before. It's not the current law. So I'm not exactly sure why they had substantiated versus alleged. I think it would be substantiated. The idea was that it was substantiated in an investigation, but I'm not exactly sure. Anne, do you have any context for that?
Yeah, it was to indicate that the investigation itself substantiated violations.
Okay.
And just to
And
be
then
clear, that because everyone is referring to, because we did have it up on the screen, is the CPHA proposal. That is kind of moot at this point because that wording was was suggestions to amend a proposal that the board had last year, which is no longer valid. So now we go back to the original language and would create a new proposal if we decided to move forward. So
okay,
it's a little bit confusing in that way.
I know, I was kind of scratching around. So where is the original, where is the current language? When I look in the chair report, oopsie, moved away from there. Is the current language, is that the BPC 2660.
Well, and that's part of what we could determine as a committee, is to work on creating language that meets certain criteria. So that wasn't part of the plan today to actually develop an amendment or legislation or to develop all those things. It was more to figure out what do we want to accomplish, and then maybe determine what the hows are. Is that going to include legislative? Is that going to include regulatory changes? What's going to be required to get to those points? I think that one of the things we don't want to do is what happened last time, is that language was submitted, it got edited so many different times, people threw everything at it, the kitchen sink, and as a result, the board did not approve it. And so we kind of are stuck going back. So we want to make sure we have a deliberative process, which means that we're not going to have language today. I think what we have today is some idea of what our needs are.
Maria, thank you for that clarification, because I wasn't part of the, I mean, I was part of obviously the board when this was coming through, but I wasn't part of the committee pane and working through it. And so, yeah, thank you for that clarification. I think I was looking at this a little bit differently.
And I think that's probably confusing to the members of the public also, is that the slide that Danny showed was a amended proposal from last year that no longer exists. And so ideally what we need to look at is what do we want to accomplish and what is that going to require? Legislatively, regulatory, that kind of stuff. So that's why these policy statements were supposed to help guide us so that we could be productive, because as you probably heard from public comment and even from board member comments, we repeat the same thing over and over, but we need to make progress instead of getting stuck in the circle of just saying the same things over and over.
I mean, it seems like the number one thing is really the number one question here. Is there a problem that we need to solve? And it seems like, and this is where I'm just really wrestling, I would love to hear the other board members' comments, because it seems like, you know, what I'm hearing from the board and the process and the presentations we've had, and maybe going back to your questions, maybe we need to have a presentation on how the investigation works. But it seems like the process that I'm hearing that happens at the board should work. But then on the other hand, the stakeholders, it seems, are telling us, but it doesn't. And so if that's the case, and it seems like we actually do have a problem, even though looking at it, it looks like we don't. And so I can't get myself past number one. And I think it is, you know, number two, consumer protection mandate. I think that's what all this is about, is, you know, how to make sure we are protecting the consumers the best. But I guess I feel like, you know, do we as a committee feel like there is a problem that we need to solve? And if there is, then I think we look at 2 through 10. But, you know, I don't know if I would love to hear from other members
And
of
I
the
think
commission.
I'm not quite sure how, other than the turnaround time and the number of cases, those kinds of metrics, how we would get to the crux of answering number one without it being kind of subjective. You know, individuals will have good outcomes or negative outcomes, and if they, you know, depending on who provides us that information, we may perceive one way or another. You know, and that's the problem with having that kind of subjective information. So we tried last meeting, and it's in our meeting materials also, is to kind of make this more objective. You know, what is the turnaround time? How many cases are going through this process? And in our last meeting, if you look at the meeting minutes, there was a lot of details about the number and the average and the overall process appears to work, but there are situations where it either doesn't work or the individuals involved are unsatisfied. Is that something that needs to be corrected? Do we have people who are silent that are not selling us too? You know, I'm like you. I'm having a hard time evaluating not only the need but the number. You know, something objective. There's nothing objective to point to.
Yeah, I agree with you 100%, because I think from our last meeting, I kind of felt like the timing and all that stuff was acceptable. I get from this meeting, like you just said, that there seems to be some problems around the process that people are coming up, and I don't know if, you know, I agree with you. The problems all seem subjective and not objective, because when we look at the turnaround times and and how, you know, how things move through, and actually, I know in the past we've compared with other boards and DCA, it seems like we're pretty good, actually.
Well, and you know, to keep us moving forward, I do have some suggestions, but I just want to give everyone a chance to speak before I talk about what I think some next steps are. But Debbie, continue to speak, but I also wanted other board members to speak, because on these 1 through 5, because I really want to get into 6 through 10, because I wanted to ask Ms. Smiley and Ann some specific questions on 6 through 10. But board members,
Well, I'm wondering if there's a kind of a best practices out there, and the way to find out if those boards that moved to an alternative method, why they wound up moving and what the results were of them moving. What did they accomplish?
Mm-hmm.
You know, I think we should maybe do some research into that.
So, moderator, can you change the slide a little bit? Because I think that's kind of where Greg is going towards, is data collection, information, kind of some planning. So I'm thinking probably number 8 is probably where you're speaking to.
Yes.
So what did the, and I apologize if I should know this, but what exactly did the physical therapy board do?
Well, I think Eileen has some information on other boards, particularly the physical therapy board. Eileen, can you help with that?
I'm trying to find that. I know the physical therapy board did not include board members, but exactly what it is, I'm sorry, I'm trying to find that from the last meeting.
Yeah, but while you're looking at that, I would probably tend to just kind of point this towards the executive officer and not getting board members involved, to be honest with you. But that's just kind of my out here in space.
Well, I mean, from what we've heard, it's not just our physical therapy board, but apparently there are boards, you know, in other states and other places that also offer these alternative methods. And I wonder if there's a way we can find out, you know, what led them to offer them, and what problem was satisfied or fixed as a result of them switching.
And I guess then question number 10 about accepting default decisions. So instead of the full board voting to accept them, we would just delegate the executive officer, since the person hasn't responded, just to accept them, and that would speed up the process. Is that what that question's about?
Yeah, it sounds like, I mean, because our hands are tied with a default judgment, all we can do is revoke. On the other hand, if we look at them, we can see if there appears to be anything wrong with them. And,
Well, but to your point, we can't really do anything about it.
Yeah.
we can't, exactly. We can't really change it. So we can set it aside if they come in and ask for it, but that's all we can do.
So I'm hearing that we have quite a bit more investigation before we can come up with a targeted plan. But do other board members have any comments on any of the policy questions or testimony that was provided?
Maria, this is Jig.
Maria. Go ahead.
For number 9 and 10, I believe that process would be a little bit more streamlined, especially revocation, surrender. I think that would make the process easier. And again, for default decisions as well. So it's time saving, and I think it just makes it easier on everybody.
So my question to Eileen and Anne, although we're not trying to come up with specific recommendations or because it seems like we still have some investigation. For 9 and 10, do you know, or would investigation be needed to figure out, would those require legislative changes? Or is that something that would be a regulatory change? Or is that just an operational issue? Where does 9 and 10 live?
Could Eileen answer that?
Hi.
Greg knows it? Go ahead, Greg.
And I'd have to look at, some of the boards have it by reg and some have it in their statutory sections. We'd have to look at if that's something that you wanted to do for the default. I'd have to take a look at this.
Okay. Yeah, and that's perfectly appropriate. We don't want to make any assumptions. And so I'm thinking where our discussions are going, and I don't want to stop this discussion, but I'm just going to throw this out here, just kind of test the temperature of the board, is I'm thinking that our suggestion is that we be looking at staff to come back with to us on some more investigation and information, considering maybe we should limit them looking at things that do not require a legislative change, starting there. And coming back to us with some suggestions, investigation of other state boards of pharmacy, other California boards, so that we could come up at our next meeting to have some tasks or some action items, I guess we could call them, so that we can actually have some action items. But I'm not sure if we're really ready for action items at this point. And also the board staff, just to be cognizant that we don't want to do what we did last time and halfway down the path, and then go to the board and then we've lost it all. We have to completely start over. There's value in our previous discussions, but I don't want us to not move forward.
Yeah,
I'm sorry,
Maria?
someone's trying to speak.
Agreed.
Yeah,
Is that Ricardo?
Yeah,
I agree.
Ricardo. Okay, there's
Yeah.
Ricardo. What I just think that we don't have our system isn't broken. I think last time we were talking about this, we were trying to find a solution where the licensee could have another form of an appeal prior to their case being thrown to where they're going to have to spend a couple $100,000 or whatever. That's where we were at. I mean,
well, I'm a little concerned about you throwing that number out because that's not been substantiated.
No, I'm just throwing that out. I'm sorry, I don't know what the amount was, but that's what it came down to. Most of them, from what we were hearing from the speakers was that they get a notice. Next thing you know, they're having to get an attorney, spend all this money, and they don't get to really tell us, that, hey, it maybe it was a misunderstanding. There was an error. It was something simple that could be solved. And I think that's what we were looking for the last time, which if there was a way of having some sort of appeal prior to it progressing to that level where they had to appear before that judge. And because everything else, I don't think we were able to find anything.
Right. So maybe, taking that in likes, we're hearing disparate information, that there are places and opportunities that maybe not understood or accessible by everyone. So maybe having a little bit more information about the investigative process, and Anne uses the word iterative. I don't know who she could have to help us understand that, but maybe breaking it down to examples and what is that discussion that happens? Because I know that during the investigation process, it's not a big surprise that you get a report. There's a discussion. And before it's everything is put in writing. And how that works, I think would be very helpful to have. Was it Anne or who suggested some sort of presentation on the investigative process?
Yeah, Anne said that. I think I like the idea.
So maybe we can, maybe our, instead of having a true motion, but we could still have some sort of action, would be to ask the staff to provide additional information, including surveys of other state boards, surveys of California boards, and a presentation on the investigative process.
Right.
Yeah, Maria, this is Ricardo again.
Mm-hmm.
When they investigate it, whether it's administrative or criminal, when they're looking at a case, I don't think we could change the way they put that investigation together. I think it was the getting to a point before it really becomes like a full-blown administrative type case or something that's going to affect the licensee.
Right. Mm-hmm. So I'm not trying to close the discussion, but I'm just trying to see if we're all on the same wavelength, checking your temperature, I guess, so to speak. Board members, do you feel like we have enough information to provide staff to do some investigation for us?
Yes.
Yeah.
And then maybe staff, you could also provide to us the clean regulation of what the current process is, so that we're not influenced by proposals from the past. And go ahead.
And maybe we can have staff look into other states or other organizations that may have a procedure that would offer a licensee an opportunity to, fix something if it's just an error or something, simple.
That's part of what we're talking about. Mm-hmm.
Yeah, exactly. But let staff research us to see something that we could change in our mission and how we do our business.
So Anne, what information do you need from us to read our minds to know what we want for the next meeting?
I think I have a pretty good sense of it if the committee members feel comfortable with me working with the chair directly to make sure that there's anything. The one question that I think I would probably ask is, are there specific types of cases that you are most interested in us exploring, right? The types of investigations that we conduct really do depend on the nature of the investigation itself. So criminal convictions versus, fraud cases versus compounding cases. So are there certain types of cases that you may be most interested in considering? Because I'm not quite sure that a one-size-fits-all is maybe where you're going to want to go long-term. So I just wanted to ask if you have thoughts in that area specifically.
Maybe that's something that I could work with you on, because I do see your point. Certainly don't want to spend time on criminal convictions as one of the areas to investigate. But I do have some ideas. And maybe you and maybe some of the chief inspectors would have some other ideas too.
Sounds good to me.
Good. I'm for it. I'm for it.
So members, we don't have any action items for this except for staff work to come back to us for additional information. Before we close this agenda item, I wanted to give you a last opportunity to make sure that everyone's been heard. Okay, great. Thank you, everyone, for your consideration. We will now take a lunch break. Let's do the lunch break until 1:15. Is that fine with everyone?
Okay.
Sounds good.
Great. Thank you all.